So, as a definition, chronic diseases are defined as diseases lasting more 1 year or more. So they require ongoing medical attention, or they can limit daily activities, like the case of diabetes, for example, if the patient is on insulin. Uh, these diseases, the chronic diseases, are the leading causes of death and disability in the United States because most of the data we have are from the United States. So they include heart disease, cancer, and diabetes as examples, but there's others for sure. So chronic diseases, they contribute significantly to the nation's 4.1 trillion annual health care costs. So as you can see, the cost is very high with these diseases, the chronic diseases. So we need to act on these diseases in order to try to reduce the cost to improve the healthcare system. So we'll start by talking a bit about diabetes. So diabetes is a chronic condition, as we said, characterized by elevated blood sugar levels. So we have chronic elevation of blood sugar. It's either due to the body is unable to produce enough insulin. So insulin is produced by the pancreas, and the body is not able to produce enough quantity of insulin, like the case of type 2 diabetes, or doesn't effectively use the insulin like type 2 diabetes. So it's either we don't have insulin like type 1, or the body does not use it properly like a type 2 diabetes. So we'll see the details later. It has a prevalence of 460 million people, and it's projected to rise to 700 million by 2045. So in 20 years, the number is expecting to double. So it's one of the most prevalent disease worldwide. And in the US alone, we have 34.2 million people with diabetes, so 10.5% of the total population, which is a big number. And each year we have 1.5 million new cases each year because, the diet influence a lot, the obesity, they have higher obesity rates because of their diet. So they are acting now on these factors. Lifestyle is very important in management of diabetes because it's not, as we said, it's not just a disease, it's a chronic condition. So it requires a lot of careful management. And as you know, uncontrolled diabetes, so uncontrolled hyperglycemia will lead to a lot of complications like stroke, kidney failure, blindness, and nerve damage because diabetes is associated with a lot of complication. So lifestyle modification is very important and has a crucial role. So it's not just about taking medication. We need to act also on the diet, the exercise, the stress management, the sleep quality. So we have a lot of factors. We have 3 or 4 types of diabetes. So we'll start with type 1. So type 1 is an autoimmune disorder. We have antibodies circulating in the system. These antibodies will go and attack the beta cells in the pancreas. So the insulin is produced by the pancreatic beta cells. So when we have these antibodies, they will go to the pancreas, they will attack these beta cells. So we have destruction of these cells, so no more production of insulin. And usually it develops in childhood or adolescence, so early on in life, but it can appear at any age also, not just at young age. So these people here, for sure, they require lifestyle modification, but here the main point is to give insulin because they don't have the cells to produce insulin. So we need to give them insulin from the beginning. The most common type, which is type 2 diabetes, here the problem is not the destruction of beta cells. We have the beta cells, they can secrete insulin, but we have resistance to insulin. So we have insulin, but the body is not being able to use this insulin properly. So it most commonly appear in adults, so at old age or adult life, but we are seeing it increasing these days in young individuals because of the increase in obesity. So we can see them in teenagers or children because of the obesity rates. Here, the most important point is to do lifestyle changes before starting therapy. And when needed, we can start oral medications, and in some cases, we can give insulin if the patient is not responsive just on oral medication and he has uncontrolled diabetes. So the third type, which is can occur in pregnant patients, is the gestational diabetes. So it occurs during pregnancy. when the body can't produce enough insulin to meet the increased needs. Because, as you know, during pregnancy, we have increase in needs, increase in metabolism. So we need to have more insulin as well in order to keep a normal glucose level. So when this occurs, there is a risk to both the mother and the baby, not just the mother, but the baby as well, because the baby will also have higher level of glucose circulating because you know it's connected. So there is a risk for the mother to develop also type 2 diabetes later in life. So it's a high risk for the patient and for her baby as well. We have also warning signs like prediabetes. It's a condition which blood sugar levels are higher than normal, but we're not yet in the diabetes range. So it's a warning sign that we need to act. Here we need to focus on lifestyle changes before the onset of diabetes. Usually, it will lead to diabetes for sure, but if we act on the risk factors or lifestyle, we can delay the progression. We can delay it by years, not just months. We can delay it a lot if we focus on lifestyle changes. So to summarize, we said we have three types: type one, type two, and gestational. So usually type one is it occurs in young individuals. Type two in older. Gestational for sure during pregnancy. The problem in type 1 is that we don't have insulin. We have insulin deficiency because it's an autoimmune disease. We have destruction of the pancreatic beta cells, so no insulin. In type 2, we have insulin, but we have resistance to insulin. The body is not able to use insulin properly. And in gestational, also, the problem here is insulin resistance and placental hormones. So type 1 is rare. It's not very frequent. Type 2 is more common, so the most common one is type 2, and gestation is becoming more common because of the increased rates of obesity. So type 1 will require insulin from the beginning. So here we need to start insulin in the beginning to avoid the complications. Type 2, we will start with lifestyle and with diet, with lifestyle. Then we can add oral medications, and sometimes they require insulin. And gestational, so also diet and lifestyle, and we can add medications as well. Okay. So to diagnose diabetes, so normally the blood glucose level should be less than 100 in patients without diabetes. When we have a fasting blood sugar, so when we measure the glucose in the morning before eating, and it's between 100 to 125, so in that case, we are in the pre-diabetes, so there's a risk to progress to diabetes in the next months or years. When we have a fasting blood sugar above 126, in that case, we can confirm the diagnosis of diabetes. So it's very important to measure the glucose level fasting, so in the morning before the meals. We can also count on hemoglobin A1C level. So hemoglobin A1C level is like a reference range for the average glucose levels in the last 3 months. So when it's less than 5.6%, it's normal, there is no diabetes. When it's between 5.7 and 6.4, it's the case of prediabetes. So here we need to act to prevent the delay, to prevent the progression to diabetes. And when it's 6.5 and above, we can confirm the diagnosis of diabetes. So we need fasting blood sugar above 126 and hemoglobin A1C above or equal to 6.5. So we need these two numbers to confirm the diagnosis of diabetes. Diabetes is also a part of a wide syndrome, which we call the metabolic syndrome. And this syndrome is also a risk factor to develop a lot of diseases like stroke, like cardiovascular diseases, like peripheral arterial disease. So it's a dangerous syndrome. So we can see this syndrome. There's measures the weight circumference in males when it's 40 and in women when it's 35. So it's part of this syndrome. We need 3 out of 5 criteria to diagnose it. So when we can say we have a metabolic syndrome. So the second criteria is fasting triglycerides when it's above 150. So it's also it gives you 1 point. When we have HDL cholesterol less than 40 in men and less than 50 in women, also it's a point. And when his blood pressure is elevated, we'll talk about hypertension later on. And when we have elevated fasting glucose, so in the pre-diabetes range, so when it's above 100, it's also a part of the metabolic syndrome. So we, diabetes and high blood glucose level is included in this metabolic syndrome. So it's a risk factor, as we said, for cardiovascular diseases, for stroke, and for a lot of other complications. Okay. So now when to screen for diabetes? So you need to know that anyone at the age of 45 years or older should be screened for diabetes at least once. So we need to do a fasting blood sugar and hemoglobin A1C for him at the age of 45 for everyone. And other cases for other ages, if the BMI is above 25 and we have one of these factors. So if the patient is inactive, he doesn't move at all, if he has first degree relative with diabetes, if he has Black ethnicity, Latino, Native American. So there's based on this ethnicity and background, if he has she has history of gestational diabetes mellitus, if he has hypertension, if he has low HDL or polycystic ovary syndrome. So all of these conditions with a BMI of equal or above 25, these patients should be screened for diabetes at any age. If the patient does not have a BMI of 25 or does not have these conditions, these patients. So very important to follow these rules. And after that, we screen them every 3 years. So let's say we measure the fasting sugar and hemoglobin A1C level today and normal. So we repeat the screening in 3 years times. Okay. So these are the guidelines to follow. This is a sign also of when you see this in the axillary region, when you see this, it's called acanthosis nigricans on the skin. So this we will need to think about diabetes when we see it. So how to delay the onset of type 2 diabetes, how to delay it or prevent it. So diet and exercise are very important. We need to, it can delay the onset of diabetes by 3 years if we follow regular exercise and diet. Smoking cessation as well, it has a modest effect. So if the patient is obese, we can offer him to do a bariatric surgery, so to lose a lot of weight is effective, especially in patients that have a BMI above 40. The usage of metformin, so we can start metformin even in the pre-diabetes in order it can delay a bit the progression to diabetes. Okay, you just need to know that insulin, if we use it early, it does not prevent or delay diabetes. So there's no point to use it early on. ACE inhibitor and other medications also, they are ineffective. So they don't prevent the delay of the diabetes. So no effect. So we need to focus on diet, exercise, and smoking cessation and weight loss. Okay, these are the most important factors to delay diabetes. Is uh, we talked about hemoglobin A1C level. We said it should be above 6.5 to diagnose diabetes. But for example, if you have a hemoglobin A1C level of 8, for example, so the average plasma glucose level in the last 3 months was 183, which is high. And if it's 12, for example, if we have a very high number, which is 12, so it means that the average plasma glucose level in the last 3 months is around 300. So hemoglobin A1C is very important to diagnose and to follow up on diabetes. So as you said, the diet is very important. So diet plays a crucial role. Carbohydrates, especially, they can increase blood sugar levels. So we need to be careful with carbohydrates. So we need to encourage a diet that is rich in whole grains, lean proteins, healthy fats, and fruits and vegetables. But we need to be careful also with fruit and vegetables because they can sometimes increase the sugar level as well. So physical activity is very important because it improves insulin sensitivity. So when we have exercise, the body will use more insulin, so the blood sugar will drop. So insulin will be used more effectively. And we need to aim, according to the articles, we need to aim at least 150 minutes of moderate intensity aerobic exercise or 75 minutes of high intensity aerobic exercise per week. So it depends on each patient. We can do a program for each patient. Not all patients can do this number of minutes, so it should be individualized for each patient. But these are the recommendations. So here is a nice study that shows you the benefit effect of exercise. So you can see for patients that does not exercise, the curve is black, and for the patients that exercise, the curve here is in blue. And you can see for the same level of insulin, for example, for insulin of 50, for the patients that does not exercise, they have less glucose uptake. So the glucose here is higher. As compared to the patients that exercise, you can see the blue curve is higher, so they have increase in glucose uptake, so the glucose in the blood will drop because the glucose uptake is higher. So exercise has a benefit here in uh, increasing the glucose uptake, so in dropping blood sugar level with exercise. So it's a nice study that studied the effect of exercise on blood glucose level. Sorry. Stress management also is very important because there's a lot of studies that show that stress can lead to elevated blood sugar levels due to increase in uh, cortisol or other hormones responsible for increasing the glucose level. So we need to act on stress reduction methods. So we need to teach the patient how to reduce the stress by a variety of methods. And if you can see this study, they studied the relation between depression, anxiety, and stress on hemoglobin A1C levels. And you can see that with increase in depression, increase in anxiety, and increase in stress, the hemoglobin A1C level is going up. So it's very correlated with the stress that the patient have. If someone is interested in reading this article, this is the title and the journal. So you can see it here. So it's associated with stress, the higher glucose levels. The importance of sleep. So sleep also is very important. So each patient should have 7 to 9 hours of quality sleep per night to support an overall health. So we need to develop a regular sleeping schedule in a comfortable sleep environment, and we need to limit the usage of TV or phones before bedtime, because light in the eyes before bedtime can alter the sleep quality. Okay. So you can see this study also. They study the duration, the relation between sleep duration and the diabetes risk. As we said, we need between 7 to 9 hours of sleep. So in this study, we have a lot of patients that are sleeping less than 7 hours. So we need to act on this population. So it's around maybe 40% of the patients included in this study, they sleep less than 7 hours. And these patients, they tend to have, in the study, they found that these patients have higher glucose levels as compared to the patients that sleep more than 7 hours. So we need to act on these categories of patients. Here also is another study about the carbohydrate counting. So we need to teach the patient to count the carbohydrate in each meal he's eating because we know that high carbohydrate levels are associated with higher glucose level. So if you can see in this graph, the blue circles are for the patients that does not count carbohydrates, and the green ones are for patients that count carbohydrates each day and with each meal. So if you can see that patients that count carbohydrates that are in green, they have all controlled hemoglobin A1C level. There's just few green circles in the uncontrolled group. You can see here and here, but they are just rare. So most of them are in this category. While the patients that does not count carbohydrates, which are in blue, you can see that the hemoglobin A1C is higher and is uncontrolled. You can see very high levels, and it's irregular pattern, so it's not very controlled. So carbohydrate counting is also very important in order to drop the blood sugar level. Here is also another one about usage of whole grain. So patients that have healthy grains in their diet, they have higher level of grains. You can see that they have lower level of mortality uh, when they consume more fiber and grains in their diet. So these are diabetic patients who have reduction in mortality. Now we talked about the lifestyle changes. We talked about the sleep. We talked about stress. We talked about the diet, the weight loss, the exercise. But let's say that we did all these things, but the glucose levels remained uncontrolled. So we have a lot of medications. The most common one is metformin. So metformin, we use it in type 2 diabetes. It can increase insulin sensitivity. So here we should have insulin in the body, but this drug will increase insulin sensitivity. So insulin will act more effectively in these cases. So we have side effects. Most commonly, we have GI side effects, so diarrhea, vomiting. It can lead to lactic acidosis and renal injury, but it's rare. So we should avoid it in patients with chronic kidney disease with lower GFR. It's very important here. Uh, okay, so all of these medications have a lot of side effects and contraindications, so we need to follow the rules. The second most commonly used medications in these days is SGLT2 inhibitors like dapagliflozin and pagliflozin. We have a lot of new medications. So these drugs, they decrease the glucose reabsorption in the kidneys. So let's say we have receptors or SGLT2 receptors in the kidneys. These drugs will act on these receptors and block them. So in that case, glucose will not be reabsorbed to the bloodstream. Glucose will be lost in the urine. So it's an effective way to lose glucose, and this medication also has cardiac benefits, so it can be used in the case of heart failure. It's now indicated in the guidelines. It improves mortality in heart failure, especially in diabetic patients, but also in non-diabetic patients. So we can give it also for non-diabetic patients in the case of heart conditions, heart failure. So here's the side effects. It can lose weight, so it's a good side effect for obese patients. So the patients can lose weight with it. The contraindication is also a severe renal impairment. We should avoid it in cases of severe renal impairment. Usually the dose is 10 milligrams and given at night. Other drugs are now less commonly used, so the sulfonylureas. These drugs, they increase insulin secretion, so we need to have healthy beta cells because these drugs will increase the insulin secretion. But here the risk to develop hypoglycemia is high. So this drug we should avoid it in older patients. اوكي we have a question. منال is asking me دكتور ممكن تعيد نقطة إعطاء الانسولين في non-diabetic patients. No منال, I was talking about كنت عم بحكي عن SGLT2 inhibitors. Whole drugs we can give them in non-diabetic patients as well if they have heart failure. So there's a mortality benefit of giving these drugs in heart failure for diabetic and for non-diabetics. So this drug is very effective. Even if the glucose level is normal and the patient is not diabetic, we can give it in case of heart failure with reduced ejection fraction or preserved ejection fraction. This is what I meant, okay? It's clear. So these drugs, SGLT2 inhibitors like dapagliflozin. Okay. So we have a lot of medications. So we just need to know the side effects, and we need to know the contraindications. So we need to be careful. So we have Manal, this is a slide for you. So I will the SGLT2 inhibitors. We said that they have cardiovascular disease benefit, mainly empagliflozin, which is FDA approved. But we have also canagliflozin and dapagliflozin. So all of these medications can be given for heart failure, even in non-diabetics, as we said. Most of other medications, they are neutral on cardiovascular disease, maybe GLP-1 receptor agonists, which are medication given subcutaneously. These are injections. So also they can benefit the heart failure. but metformin also potential benefit, we're not very sure, but most others are neutral. And we have some of these medications that can increase the risk of heart failure, like the DPP-4 inhibitors and diazolidinediones. So they have a risk to worsen heart failure. Okay, so we need to know all these benefits. If the patient, so we did lifestyle modifications and we gave them per us or oral medications, as they don't have a normal or controlled blood glucose level. In that case, we can start them on insulin therapy. So we have different types of insulin. We have the rapid acting insulin. So these insulin are given before or after meals. We give them 3 times per day. And we have the long acting insulin. So we have types of insulins that can last for 12 to 24 hours. So these are called the basal insulin. So they can last for 24 hours. So we have the two types. You need to know that we have the rapid insulin and we have the basal long-acting insulin. So a lot of patients will take both because we need basal to keep a level of insulin in the circulation for 24 hours, and we need a rapid insulin to have peaks of insulin, especially when the patient eats, to avoid the episodes of hyperglycemia. So we have a lot of types. We just need to know that the rapid acting insulin will just need 5 to 15 minutes to start working, and the effect will peak at 45 minutes usually, and the duration of efficacy is between 2 to 4 hours for the rapid acting insulin. Okay, as compared to 24 hours for the long acting. You need to know that we have a lot of complications associated with diabetes. So we have what we call the macrovascular complications and the microvascular complications. Diabetes can lead to stroke because it will cause vessel damage. It will lead to heart disease and hypertension on the long term. It can lead to peripheral vessel disease, so the patient will have problems in all his vessels, so in this brain, in the coronary arteries in the heart, in the peripheral vessel. Will have foot problems. So you know that a lot of diabetic patients developed diabetes foot, what we call. So we can have amputations in these patients because of the vascular problems or arterial arterial damage, so less blood flow will reach the extremities, so there is a risk of necrosis of these extremities. We can also have microvascular, so small vessel diseases like the vessels in the eye, so we can have retinopathy, we can have nephropathy, so kidney diabetes nephropathy, and we can have neuropathy, so the patient will have pain, chronic pain, mainly in the extremities, so the patient will come to us and will complain of peripheral pain. So we need also to always to think of diabetes in such cases. So food problems, as we said, in macrovascular and microvascular. So now it's very important to know when to screen for these complications. So should we screen everyone for this complication, everyone with diabetes, or we should follow some rules? For sure, we have some rules. So when we want to screen for retinopathy, so in type 1, we start screening at 5 years after diagnosis. So let's say today we diagnosed a patient with type 1 diabetes. We don't screen retinopathy on diagnosis. We wait for 5 years. And then after 5 years, we start doing it annually. And we need to send him to the ophthalmologist to do it. Not everyone can do this test. So we have the eye examination to screen for it. While in type 2 diabetes, you need to screen for this complication at diagnosis. So let's say today we diagnose someone with type 2 diabetes, we need to send him directly to the ophthalmologist in order to do the eye examination. And then if it's normal, we repeat the screening each year. In pregnant women as well, so we have to start screening. We have to do the screening in the first trimester. So also the first trimester, we do the eye exam. Okay. Now, when we talk about the nephropathy is very common in diabetes. So you see a lot of patients with diabetes. They have chronic kidney disease. A lot of them are on dialysis. So if they have type 1 diabetes, Same for retinopathy, we screen at 5 years after diagnosis and annually. So not on diagnosis, but 5 years after. And you need to do the albumin creatinine ratio in the urine. So you do a urine analysis test and you ask for the albumin creatinine ratio. When it's high, it's associated with nephropathy. While in type 2 diabetes, like we said for retinopathy, we need to screen this disease at diagnosis. So today we diagnose diabetes, we do the albumin creatinine ratio directly. Then annually, so the same for retinopathy. And if the value is abnormal, we send the patient to the nephrologist as well to follow up with him. Neuropathy, same. So for type 1, 5 years after, then annually, and type 2 at diagnosis, then annually. And there is a test, so we call it 10-gram monofilament test, which will test for the neurologic sensation in the extremities. The only difference here is for cardiovascular diseases, so like hypertension and dyslipidemia. So for type 1 and type 2, we need to test for hypertension and hyperlipidemia at diagnosis. So we don't wait for 5 years in type 1, but at diagnosis. And each visit, we need to measure his blood pressure, while the lipid panel, we tested annually, and it should be fasting lipid, not after meals, it should be fasting. So the only condition where we screen at diagnosis in type 1 is hypertension and dyslipidemia. All other cases for type 1, we screen after 5 years after diagnosis, and type 2, we always screen at diagnosis. So we send the patient to the ophthalmologist, we do the urine test, and if abnormal, we send them to the nephrologist, and we also do the test for the neuropathy. And the blood pressure, anyone can do it. We measure the blood pressure for patient regardless of our specialty. And the hyperlipidemia, we also do the lipid panel test each year. Here is an example of a patient with diabetes. Look at his coronary arteries. This is the right coronary artery. So he had a very tortuous right coronary artery and a 99% stenosis. So this patient presented with myocardial infarction, and he was treated with coronary stenting. So a stent was placed here, and blood flow was preserved. So these are the arteries of diabetic patients. So there's a high risk to develop vascular complications and coronary artery disease as well. So what is the complications we can have with diabetes, mainly in type 1? So there is a risk of developing diabetes ketoacidosis. So DKA and hyperosmolar non-ketotic hyperglycemia. This we see it in type 2 diabetes, while DKA we see it most commonly in type 1 diabetes. And the problem here is the lack of insulin to have DKA. So we have ketoacidosis, we have ketones production, we have acid production, because insulin prevents the ketone or acid production. And when you don't have insulin, there is a risk to develop DKA. We see this mainly in patients with type 1 diabetes that are poorly compliant with their insulin. So we see DKA a lot in these patients. So how to treat? We need to give aggressive fluid when we have DKA or hyperosmolar hyperglycememia. We need to give a lot of fluids. So we need to sometimes give 0.9% normal saline at 1 liter per hour. We start with this, and then we decrease the dose progressively. We need to give intravenous insulin. So we need to give high doses of intravenous insulin until the anion gap acidosis is resolved. So until the acidemia is resolved in DKA. So we need to give IV insulin. We need to be careful with potassium, because giving a lot of potassium, a lot of fluids can sometimes drop the potassium level and cause severe hypokalemia. So we need to administer potassium level, and we need to do the potassium level frequently. So mainly every 2 hours, we need to test for the potassium. So fluids, insulin, and monitor potassium and monitor acidosis. You stop IV insulin when the acidosis is normalized, and you start with high fluid and you decrease progressively. Okay, so this is how we treat diabetes ketoacidosis and hyperosmolar states briefly. So now we finished with diabetes. Is it clear? Do you have any question before we move to the second chronic disease, which is hypertension? Clear for you? Okay. We'll have also at the end few minutes for questions as well if you have. So we will continue with hypertension. So hypertension is the second chronic disease that we will discuss today. So you need to know that hypertension can be primary, or also known as essential hypertension, so without any evident cause, or it can be secondary hypertension, which can be related to specific causes that we will discuss within this lecture. So most cases are primary hypertension. We don't have a clear evidence of why we have hypertension in these patients. And it's the origin of primary hypertension is complex. So we have a lot of environmental factors, a lot of genetic factors. So we have DNA factors, environmental. So we will see. Genetic and environment factors, so they affect cardiovascular regulatory system. So they increase systemic vascular resistance. And when we have vascular resistance, we have a lot of genetic factors. So we have more than 1,000 genes related to the blood pressure, but we don't understand this yet accurately because I think by the years we will have treatment that can target these modified genes in order to treat blood pressure and to cure blood pressure. For now, we can give treatment just to drop the blood pressure, but we can't cure it. But if we act on this level of the DNA or genetic levels, maybe we can reverse the hypertension in these patients. But we don't have this technology yet. So environmental factors like air pollution, noise, if someone lives in an area with a lot of noise, so these can increase the risk to develop hypertension. So we need to be careful of these factors. You can see here that the development of hypertension is very complicated. So we said we have genetic factors, we have more than 1,000 genes already identified. We have lifestyle factors like stress, sleep quality, physical activity, smoking, alcohol, and diet. All of these factors are associated with increased risk of hypertension. So we can see that these are the same factors related to diabetes as well. So the metabolic syndrome, because high blood pressure is also in the metabolic syndrome. So the same factors that we need to act on. Environmental you said the ambient temperature, the noise exposure, if we live in an area with a lot of noise, air pollution in a polluted area with a lot of factories or so it depends also on the area. We have factors that can decrease the blood pressure, and we have factors that also can increase the blood pressure. So the factors that can decrease the blood pressure, like prostacyclin, natriuretic peptides, nitric oxide, while factors that can increase the blood pressure, we have the endothelins, we have the activation of the sympathetic nervous system and the renin, angiotensin, aldosterone system. So all of these are physiologic factors that act on dropping and on increasing the blood pressure. So you can see it's a very complicated disease. So we have factors affecting blood pressure regulation, we have genetic factors, we have lifestyle factor, and we have environmental factors. So it's very complex. So now what are the ranges of blood pressure? So normally the normal blood pressure should be between 120 to 129 systolic. So this is the 2023 guidelines. So the normal blood pressure systolic should be between 120 and 129, and the ideal, the optimal should be less than 120, and the diastolic should be either less than 80 or between 80 to 84 to say it's normal. These are the normal ranges. When we have a systolic pressure between 130 to 139 millimeter mercury and diastolic of 85 to 89, this is considered high normal. So here we need to start acting on the high normal to prevent the progression to grade 1, grade 2, grade 3. Grade 1, you can see systolic between 140 to 159, grade 2, 160 to 179, and grade 3 is 180. Here we need for sure to be on therapy when you see these levels. You can have a disease called isolated diastolic hypertension. So the systolic pressure is less than 40, but the diastolic is always above 90. So we should treat these patients as well, even if their systolic blood pressure is normal, but their diastolic blood pressure is also associated with a lot of complications. So we need to treat even if we have isolated diastolic hypertension. So you can see here when we combine hypertension, so let's say we have stage 1 hypertension. Stage 1, we said 140 to 159 systolic. So when we have this, and if we add to it other risk factors like diabetes, like CKD, like hyperlipidemia, we can classify the patient based on the risk. So if we combine these factors, you can see we can have low risk, moderate to high risk, and high risk, and very high risk. So each patient, we should put him in the category. So based on the blood pressure and the other risk factors associated with hypertension. So you can see if he has a very high risk and he has age of less than 50, the cardiovascular risk of complication and mortality within a few years, it's 7.5%. And when the age goes up, also the risk will go up with age. So we have the blood pressure, we have the risk factor, and we have the age. All of these will increase the risks of complications. So the guidelines tell us that even if you're of any specialty, so you just don't have to be a cardiologist or a doctor. So when you see a patient coming for any other reason, we always have to measure his blood pressure, even if he comes, for example, for fever or for any other condition, we need to measure the blood pressure. It's class 1 recommendation in all adults. And we should start screening for hypertension at the age of 40 for everyone, or if earlier if the patient has a high risk to develop hypertension, so he has family history, he has the risk factors that we already discussed. And in individuals hypertension, so we should see the patient in a few weeks to confirm the diagnosis. We'll see this in the next slide. So it's recommended to diagnose hypertension, you need 2 separate office visits. So let's say the patient comes today, we find, for example, a systolic blood pressure of 150. We ask them to come back in 4 weeks, and we repeat. If we find the same value, we confirm the diagnosis of high blood pressure. When we have a blood pressure of above 180 to 110 in the first visit, here we don't need to see him in 4 weeks. We can confirm the diagnosis of hypertension directly. So, and we start therapy from the first time. But for other cases, we need to see him at least for 4 weeks in a second visit within 4 weeks. And if we find all the blood pressure to be always elevated, we start therapy in that case. Okay. So sometimes also you can see that we have difference between the left arm and the right arm. So if we have difference of more than 15 to 20, here we need to suspect atheromatous disease affecting the circulation either on the left side or on the right side. And if we want to repeat the measurement, you always repeat on the arm with the highest blood pressure. So let's say on the right we have 120 systolic, on the left we have 100. If we want to repeat the blood pressure later on, you always repeat on the right side. Okay, so we said if the patient comes to our office, we need to take 3 readings within 1 minute interval between, so not just once, because we need to repeat the reading 3 times. If we have high blood pressure, we ask him to come back in 4 weeks' time to confirm. If the patient is measuring his blood pressure at home, so he should take 2 readings within 1 minute interval, and he should note the reading on a paper. He should do this at least for a week, and when he comes back to his doctor, he shows him the paper morning and night, the average blood pressure. So it's very important to use a validated device to measure the blood pressure. Not all devices are good. We need to be careful to use the appropriate devices. We should measure the blood pressure in a quiet room. The patient should not smoke or drink coffee, and 30 minutes before measurement. It's very important, the patient should be seated for 5 minutes. We should not measure the blood pressure directly when he arrives. We should wait 5 minutes before starting to measure the blood pressure. And the patient should not be talking when we are measuring his blood pressure. So it's very important also for the patient to be sitting in a good way. So you need to sitting with the back supported by a chair. The legs should not be crossed. When we cross the legs, we increase the blood pressure. So it's very important to follow these steps. So we have 8 steps to accurately measure the blood pressure. Sometimes we ask the patient to do uh, ambulatory blood pressure monitoring. So especially for patients with white coat hypertension. So white coat hypertension are the category of patients that have normal blood pressure at home, but when they come to the doctor, the blood pressure will go up, maybe due to anxiety, due to stress. So it's white coat hypertension. So in these patients, we need to focus on home blood pressure measurement because at home it's normal, but in the office it's high. So we ask them to measure the blood pressure at home and to note it on a paper. Okay, so it's also important, the home blood pressure monitoring is important to follow up on treatment. So when we start a treatment, we ask the patient to always measure his blood pressure to see if it's well controlled or not. So here is another detailed table, but we already discussed all these topics. We'll skip. So let's say we diagnosed a patient now with hypertension. So what we need to see in his physical examination. So when we start to examining him, we need to check if he's overweight or not. We need to calculate his BMI. If his BMI is high, we should act to drop his weight with diet, with exercise, with lifestyle modifications. If he has a high weight circumference, we said weight circumference is associated with metabolic syndrome, so associated with complication. So here also we need to act properly. We need to see if the patient have complications related to hypertension, so neurologic deficits. We need to do the eye exam, the same that we did for the diabetes, the eye examination. Also, we can have retinopathy with hypertension, so hypertensive retinopathy, mainly for very high blood pressures levels. We need to auscultate the heart to check if we have any problem on the valves of the heart. We need to palpate the carotid and peripheral arteries because also hypertension can cause peripheral artery disease. So also we need to screen for secondary hypertension because we said that we have a lot of diseases that can be associated with secondary causes of hypertension, like for example pheochromocytoma. We can see café au lait spots. These are skin lesions that we can see in neurofibromatosis or pheochromocytoma. We need to palpate the kidneys to see if the kidneys are enlarged because, as you know, polycystic kidney disease can cause kidney enlargement and is associated with high level of blood pressures. So also we need to see if we have Cushing disease. Cushing disease also have features. We will see it in the next few slides. And thyroid disease, so hypothyroidism or hyperthyroidism can sometimes cause high blood pressure as well. So we always need you need to examine all these sections. And when we diagnose hypertension also, we need to check hemoglobin levels, see if we always have to ask for hemoglobin levels. We need to screen for diabetes as well because diabetes can be associated with hypertension. We need to screen for hyperlipidemia because also hyperlipidemia can be associated. You need to measure potassium, sodium, uric acid, creatinine, and glomerular filtration rate. Why? Because hypertension can lead to hypertension nephropathy, like diabetes nephropathy. So we always need to follow up on the creatinine level. Blood calcium, because hypercalcemia is associated with hypertension as well. So high level of calcium is a secondary cause of hypertension. And urine analysis also to screen for albumin creatinine ratio, like we did in diabetes, to screen for hypertensive nephropathy. We also need to do for sure an ECG, and as we said, because on the ECG we can see signs of left ventricular hypertrophy and long-standing hypertension. It will lead to the thickening of the myocardium. So we'll have left ventricular hypertrophy if the patient has hypertension for a long time. So we need to always do an ECG. If we see these signs, we can ask for an echo to confirm the left ventricular hypertrophy. Okay. So it's very important. Now, when to look for secondary hypertension? So let's say we have a patient that is less than 40 and he comes with grade 2 or grade 3 hypertension. So in that case, we need to suspect a secondary cause. So why is this patient at 20 years, for example, he will have a blood pressure of 180. So in that case, we need to screen for the secondary causes. If the patient comes with hypertensive emergency, for example, a blood pressure of 200, in that case, we need to screen for secondary causes of hypertension. Or if a patient, for example, that is known to have a normal blood pressure, but he have acute worsening of blood pressure, we don't know why, and it's mainly in young patients. So in these patients, we screen also for secondary causes. Also in pregnant patients, when the blood pressure is very high, or it's blood pressure we have acute worsening of the blood pressure in pregnant without pre-existing hypertension. We also need to screen for secondary causes of hypertension. So what are the secondary causes? You can see here are all the secondary causes, and you can see the age group. For example, if the blood pressure is high between 1 to 12 years, we can have aortic syndromes, so coarctation of the aorta, renal parenchymal disease, so renal disease, renal vascular hypertension, like fibromuscular dysplasia, and so this is for 1 to 12 years. If the age goes up, you can see we have the same ones, and we have others like renovascular hypertension or atherosclerotic disease. So this is due to the cholesterol deposition in the renal artery. This start to appear at the age of 40. It's very rare to have it before 40 because cholesterol will start to cause problem in arteries, in all arteries, not just cardiac arteries, in renal arteries as well, starting at the age of 40. So the first disease that can cause secondary hypertension, we said atherosclerotic renovascular disease. So you can see here these are the renal arteries, and on the yellow ones is the cholesterol deposits on these renal arteries. So we have narrowing of the blood flow reaching the kidneys. So in these patients, uh, when the prevalence is 6 to 14% of patients, they have cholesterol deposition here. It can cause resistant hypertension. It can cause flash pulmonary edema. For example, if an old patient comes with repetitive flash pulmonary edema, we always need to look on his renal arteries to see if we have this disease or not. It can cause rapid decline in kidney function because we said we have less blood flow reaching the kidneys. So here, how to screen for it, we need to do a renal ultrasound. So we ask for an ultrasound to look for narrowing of these arteries. And if needed, we can ask for an angio CT scan. Also, it's more accurate, but here the risk is to give contrast. So they already have kidney injury. So when we give them the contrast, it will worsen the situation. And to treat it, we need to give antihypertensive medications to treat the hyperlipidemia because this is associated with increased cardiovascular risk mortality. So not just the hypertension, the cardiovascular risk and the mortality are going up with this condition. The second one is the fibromuscular dysplasia. This one usually it occurs in females. It's less frequent, so 1 to 6%, and it's more frequent in females. So if you see the renal artery, so we have narrowing and dilation, narrowing and dilation. So it's irregular renal artery. Usually it's unilateral, just or bilateral sometimes. But associated symptoms, so hypertension, it can cause migraines, can cause pulsatile tinnitus, so you can hear a noise in your ears. So also the first screening test is renal ultrasound, like we said in renovascular hypertension, and we need to start them on antihypertensive therapy. And sometimes we need to do a balloon dilation. So we send the balloon to this area and we inflate it in order to make the artery more regular. So it's associated with a lot of cardiovascular complications, and you need to know that it can affect most arteries, not just the renal arteries. It can affect the brain arteries. It can cause dissection and then cause aneurysms elsewhere in the body. So not just the renal arteries. The third one is primary hyperaldosteronism. You can see hyperaldosteronism is when we have a tumor on the adrenal gland. So this tumor will start to secrete a lot of aldosterone. So it can cause resistant hypertension or high grade hypertension, so grade 2, grade 3. It can lead to hypokalemia because aldosterone will drop the potassium level. So when we see a very profound hypokalemia, with hypertension, we need to think about this disease. And to screen it, you need to measure the aldosterone to renin ratio. So you always ask for aldosterone and renin ratio, and you need to order a CT scan in order to see this tumor, to see if it's unilateral or it's bilateral. If it's unilateral, so on just one adrenal gland, so in that case, we can do a surgical treatment. While if it's bilateral, in that case, you can't remove both adrenal glands. In that case, you just give medical therapy. You give aldosterone antagonists. So you act just medically. If it's unilateral, you remove it. But bilateral, you need here to give aldosterone antagonist. And this disease was also shown to be associated with increased cardiovascular risk and mortality. Pheochromocytoma is the first disease. It's rare. You can see it's less than 1%. So here also, it's a tumor on the adrenal gland, so the gland above the kidney. We have a tumor that is secreting a lot of metanephrine or catecholamines. So the symptoms will be paroxysmal symptoms such as headaches, sweating, palpitations. The patient will report episodes of tachycardia, of headaches, of increased heart rate associated with high blood pressure. So it's episodic, not all the time. So how to screen? We screen by asking for plasma or urine metanephrines as well. So it's a blood test here. And when we find abnormal values, we ask for a CT scan, and the CT scan will show us that we have a tumor on the adrenal glands. So here the treatment is surgical resection. We can do it by invasive laparoscopic adrenalectomy. And also, it's associated with increased cardiovascular risk and mortality, like the other secondary causes of hypertension. But here, it's less prevalent, so less than 1% of cases. Cushing disease, the last one that we will discuss. This is a disease that affects 2 to 5% of patients with secondary hypertension. So it will cause resistant hypertension. It will cause easy bruising on the skin, so he can bleed easily on the skin. Facial patera, moon faces, you can see his head is a bit enlarged. So skin thinning with the skin will be more thin. So proximal myopathy, he have weight gain, you can see he's obese. He can have diabetes mellitus also because of the high level of cortisol. So this disease the patient will have high level of cortisol. So to diagnose it, we have a lot of tests, but mainly we use the dexamethasone suppression test as a test to diagnose this disease. You can also measure the free cortisol in the urine or in the saliva. And when we confirm abnormal levels, in that case, we can do either a CT scan or we can do the ACTH morning levels. And the treatment here, we start with medical to normalize the cortisol levels, and we can do the surgical also, the surgical treatment. It also associated with increased cardiovascular risk and mortality. So all of these diseases are found to be associated with increase and mortality. Not just high blood pressure, but mortality also is higher. Okay. So now, how to treat high blood pressure? So let's say we have a patient with grade 1 hypertension that is asymptomatic, okay? And we need to confirm this by asking him to come back 4 weeks later in order to repeat the measurement to confirm that he has grade 1 hypertension, okay? So when the diagnosis is established, so we're talking here about grade 1, if the blood pressure is less than 150 to 95, okay, uh, here you do the lifestyle modifications, and if it's not controlled, this blood pressure, then you add a medication, okay? But in cases of grade 1 that is symptomatic or grade 2, so grade 1 that is symptomatic or grade 2 or above, here you need to do lifestyle, but you need to immediately start drug therapy. So the only case that you don't start drug therapy initially is the case of grade 1 hypertension that is asymptomatic and that has a controlled blood pressure. So here you wait on lifestyle and then you add a medication. But in all other cases, when you have grade 2 or grade 1 that is symptomatic, we need to do lifestyle modification for everyone. Then you need to start directly blood pressure lowering medications here. And you need to aim for optimal blood pressure control within 3 months. So you need to see the patient within 3 months in order to confirm that he has controlled blood pressure levels. So uh, in patients that are in the 18 to 79 year of age, so here the threshold to start therapy is 140 millimeter mercury systolic or 90 diastolic. Any values less than these numbers, we can wait on lifestyle. But if it remains like this, we need to act by adding a medication. For patients that have 80 years or older, here we should be a bit more. We should be more careful. We can wait for the blood pressure to reach 160. So we should be more careful in older patients because here is the risk of hypotension, and you know if an old patient develops hypertension, there is a risk of fall or trauma and fractures, which will cause a lot of complications. So older age, we should be more careful with when to start the blood pressure medication. And what is the goal? Let's say we started the therapy in patients between 18 to 64. So the goal in 3 months is to drop the blood pressure to less than 130 over 80 for this age group. While for older patients between 65 to 79, here the goal is to drop the blood pressure to less than 140 over 80 within 3 months. So you can see as we grow up, the target is a bit higher because you don't want to have hypotension. We don't want to be very aggressive with the therapy. And for patients with 80, as we said here, the target is 100, 140, 140 to 100 to 150 range of systolic blood pressure. So we should be less aggressive with these patients. So the drugs that we have 4 types of main drugs that we use in hypertension. We have the ACE inhibitors or angiotensin receptor blockers. These acts on the angiotensin renin aldosterone system. We have the calcium channel blockers. So the calcium channel blockers are purely vasodilator medications. They vasodilate, they drop the systemic resistance, and by this mechanism, they drop the blood pressure. Beta blockers, mainly these medications act on the heart contractility or heart rate, but also they have the property to drop the blood pressure because they inhibit the sympathetic system. So they tend to drop the blood pressure as well. And diuresis, so diuretic also, when we decrease the volume, we drop the blood pressure. So sometimes we can use combination of these medications. Sometimes we use monotherapy, but most of the time we need to combine 2 medications. And you need to combine them, and you need to up titrate to the maximum well-tolerated dose. So you don't just leave the patient on the lowest dose. If the blood pressure is uncontrolled, you need to increase the dose to the maximum tolerated dose. So we'll not go into the details, but you need to know that ACE inhibitor and ARBs are contraindicated in pregnant patients. So we should stop them in pregnant. And for patients that have potassium level above 5.5, there's a risk of hyperkalemia with these medications. Also, beta blockers should be avoided in severe asthma because of the risk of bronchospasm. Also should not be used in case of high-grade AV block. And in cases of bradycardia less than 60, we should decrease the dose or avoid the usages. Okay. Also, mineralocorticoid receptor antagonist, so the aldosterone antagonist, also should be avoided in potassium above 5.5 and in cases of decrease in kidney function. Same for ACE and ARB. So mainly we should be careful with potassium. For ACE, ARB, and MRA, we should be careful with asthma for beta blockers. And for diuretics, we should be careful with hyponatremia because they cause hyponatremia, mainly the thiazide type of diuretics. Okay. So it's really now the guidelines, the 2023 guidelines, they recommend to start with 2-drug combination for most hypertensive patients. So it's better to start with a combination rather than start with just one medication alone, because studies found that combining 2 drugs has decreased complications and mortality. So it's better to combine two drugs. Okay. If the blood pressure is not controlled with the initial two drugs combination therapy on the maximum tolerated dose, we then can add a third drug. So, for example, if the patient is on an ACE inhibitor and a calcium channel blocker, he's not controlled on the maximum tolerated dose, then we can add either a beta blocker or a thiazide diuretic. So we'll be on a three therapy. So you should not be afraid of adding drugs. We need to have the target blood pressure. So we need to increase the dose and add other drugs in order to be in this range. So now we have single pill medications containing two drugs. For example, we have drugs that contains a calcium channel blocker and an ACE inhibitor. So we have combination of a single pill. This will improve the patient compliance. The patient will not skip medications because the two medications are contained in just one pill. So these drugs are very important and they are recommended by the guidelines as class 1 recommendation. So it's better than giving two drugs. It's better to give a single pill containing these two drugs. You should be also careful. We should not give ACE inhibitors and ARB at the same time for the same patient because these two drugs, when given together, they increase the risk of adverse events, mainly acute kidney injury and hyperkalemia. So they can lead to arrhythmias because of the hyperkalemia. So you should not combine ACE and ARB together. It's contraindicated. It's class 3. It causes harm to the patient. Okay. So now when we say that we have resistant hypertension, so resistant hypertension is the persistence of elevated blood pressure, systolic above 140, diastolic above 90, in a patient that is on maximum dose of three drug combination therapy, including a diuretic. So let's say we have a patient on calcium channel blocker, on ACE inhibitor, and on thiazide on the maximum dose of this medication, and this patient is always have a blood pressure that is uncontrolled above 140 to 90. So in that case, we need to make sure he doesn't have a secondary type of hypertension or, for example, white coat hypertension. So we need to ask him to measure the blood pressure at home as well, not just in the office. So when we have this, so the patient is on three therapy and still uncontrolled, you always need to check for the kidney function. If the kidney function is relatively good, so above 30 is a clearance, in that case, the patient is already on ACE and TCB and diuretic. In that case, you can add an MRA, so aldosterone antagonist, which is the preferred drug to add in this case. But you need to be careful, as you said, with the potassium and the creatinine levels. You need to always follow up. Second line, you can add a beta blocker or alpha blocker. And if the patient is already on three drugs and on maximum dose, but he has a kidney problem, but he's not on dialysis yet, but the clearance is less than 30, in that case, in that case, you can add chlortalidone, which is also a diuretic. Uh, in addition to the loop, diuretic is already on, and you can add also a beta blocker or alpha blocker or a centrally acting agent. So we have drugs that acts on the alpha 2 receptors in the brain, so they tend to drop the blood pressure. We call them centrally acting drugs. So it's very important to understand the idea of resistant hypertension. So resistant hypertension, we said the patient should be already on three drugs therapy, so ACE, CCB, and a diuretic on maximum dose. And he has always a blood pressure of above 140 to 90. And when we see this, you always need to check the kidney function. If the kidney function is good, you add spironolactone, so he'll be on four drugs therapy. If the kidney function is not good, you replace the thiazide diuretic with a loop diuretic, and you add a chlortalidone. Okay, so this is about the resistant hypertension. And that was it about chronic diseases. So we talked about diabetes and hypertension. So if you have any questions, we have 2 minutes to answer them. If you have any questions, please write them in the chat before moving to the next presentation. Thank you for listening. Can you see the slides? I shared the second presentation. Is it clear, the slides? Please write in the chat if you can see the slides. Okay, thank you. Thank you. Okay, great. So you can see it. We'll start. So this is the second lecture of the day. It's about the usage of technology in chronic care. So we are continuing the topic on how to improve quality of life in chronic diseases. So now we'll talk about the usage of technology in such cases. So, as an introduction, you need to know that technology in healthcare in these days is mainly about remote patient monitoring. So, remote patient monitoring refers to the use of technology to collect patient data outside of traditionally healthcare settings. So, all these patients, like we discussed about hypertension and diabetes in the first lectures, so they are not always present in our clinics or in the hospital. So, we need to follow them even when they are at home or outside the healthcare settings. So we need continuous monitoring for these patients, health parameters like vital signs, like glucose level, like blood pressures. So this will facilitate the communication between patients and healthcare providers. Okay. So remote patient monitoring is the main use of technology now in chronic care. So the usage of technology, it will empower patients by providing them with tools and devices. So we give them devices to measure their vital signs, for example. And by doing this, they are active participant in their healthcare. So they now understand uh, how their disease is going, the progression of their disease. They are more active in the therapy they are getting. And the shift towards using technology in chronic care also transforms the traditional model of care delivery, so to make it more patient-centric and adaptable to the needs of the modern digitally connected world. So the patient will be more involved, and as you know, the technology is taking over all aspects of life. So we have artificial intelligence, we have a lot of things going on recently. So we need to add these things also to the healthcare to stay updated on on all the new technologies. So it's very important to add it. We have monitoring devices. So as you know, we have wearable devices like sensors, like smartwatches. It's very commonly used. Even it's now FDA approved to use it. We have medical grade devices. So all of these devices, they can collect real-time data, vital sign, mainly heart rate, blood pressure, activity levels, number of steps, and other relevant health metrics. So we'll discuss these devices. You can see that we can have these digital devices, the thermometer, the pulse oximeter, the weight scale. Weight scale is very important because mainly in patients that had heart failure, for example, you need to measure daily weight. If the weight is increasing, it means that the patient is overloaded, so we need to increase the diuretic dose. All of this can be done at home, so no need to send the patient to the hospital each time. So he just contact his doctor or his nurse, and the nurse or his doctor will tell him to increase the medication dose. The blood pressure, glucose meter for hypertension and for diabetes. So we have a lot of tools that can be connected and monitored by the healthcare provider. So you all heard about the wearable smartwatches. So these watches are very important, mainly for the diagnosis of underlying cardiac arrhythmias. So mainly for the diagnosis of atrial fibrillation. Okay, so these drugs, these watches, you can see can give you a single lead ECG tracing for 60 seconds, for example. You can see this rhythm is irregular. So this is atrial fibrillation. In fact, so this patient is having undiagnosed atrial fibrillation, and the smartwatch he's using allowed us to detect this arrhythmia even without seeing his doctor. So the smartwatch was very effective in that case. And they did this study and they asked a lot of doctors or nurses or healthcare workers if they can rely on this tracing to diagnose atrial fibrillation. And 83% said yes. So they diagnosed atrial fibrillation based on this. And from these 83%, 72.8% said also that they started the therapy treating this arrhythmia. So they start giving anticoagulation for this arrhythmia uh, by just seeing the data from the smartwatch or the wearable rhythm device recording. So these devices are now FDA approved, so we can use them. We can advise the patient to use them. These are very effective. You need also to know that these devices and these technologies were not very frequently used before the COVID pandemic. You can see after the COVID, during the COVID pandemic, and after the COVID pandemic, we have a shift of healthcare toward a bit of virtual or telemedicine. So by using the technology that we discovered during the pandemic, we tend to keep using it, but you can see after the COVID pandemic, it's dropping a bit, but it's still higher than before the COVID pandemic. So now I will talk more about these wearable or smartwatches. You can see that the smartwatches, if we compare it to pulse taking, so if you compare it to manual pulse taking by putting our fingers on the radial artery to measure the pulse, to diagnose irregular heartbeats or atrial fibrillation. So pulse taking you can have a sensitivity of 87 to 97% to diagnose AFib. But when you use the smartwatches, you can see that the sensitivity is a lot higher, so 87 to 99%. So it has a very accurate, it's a very accurate tool to diagnose atrial fibrillation. So it has a higher sensitivity than the traditional way of pulse taking. So how this watch can give you the tracing? So a lot of these watches, you put your finger, you put your thumb on a sensor here on the watch, and you can see it will start to give you the ECG, single lead ECG tracing, and it uses algorithms to differentiate, so artificial intelligence algorithm to differentiate between normal sinus rhythm, regular rhythm, and irregular rhythm, atrial fibrillation. So it will give alarms when we have atrial fibrillation. Okay. So there's a lot of studies about these watches, and you can see the study is published in 2018 in the Journal of American College of Cardiology. So this is an example. You can see the tracing, the ECG tracing. It gives you the exact heart rate, 63 beats per minute, the time. And here the patient can send a voice or can type, for example, that he's feeling, for example, palpitations or chest pain or any other symptoms, he can add it. And after that, his doctor will receive all these informations and he will know exactly what did the patient feel when he had this ECG tracing. Usually patients that have atrial fibrillation, they can feel palpitations in their chest, they can feel faster heart rates, they can feel headache, they can feel vertigo, so they can note their symptoms. In that way, the doctor will be able to correlate these symptoms with the arrhythmia to confirm that this arrhythmia is really causing these symptoms. Here is also another study published in 2019 about the smartwatches' performances, and they analyzed more than 31,000 hours of simultaneous recordings. And they found out that these devices are 97% sensitive for diagnosing atrial fibrillation episodes. So it confirmed the previous study. We had 97 to 99%. So here we had 97.5%. So also it's we confirmed because they studied a lot of hours. So it's very sensitive and very effective device to use for diagnosing arrhythmias. But you need to know also that we can have false positives. So we just don't have to rely on it. We always need to see the tracings, not just see the alarms. You need to analyze the tracing. Because, for example, if you look on this tracing here, you can see the complexes with a green dot on top are normal complexes because we have P waves followed by QRS followed by T wave. Here, it's not the topic today to talk about ECGs, but you need to know that we have false positive. The blue complex is a premature beat, but the device detected it as atrial fibrillation, which in fact this is sinus rhythm associated with frequent premature beats. We call it this atrial bigeminy. It's not atrial fibrillation here, it's atrial or frequent premature beats. It's not atrial fibrillation, but the device detected it as atrial fibrillation. So we can have false positive. You always need to check the tracings, not just check the report. You need to analyze the tracing, and if needed, you do a 12-lead ECG in the office. So here is also another trial. They compared the performance of smartwatches against the traditional 12-lead ECG, and you can see it was very accurate. The Apple Watch, it was 93% accurate. Other types also, they were above 90% accurate. So it's as compared to the ECG, we can rely on it as well. Here is the approved devices that we have in the market. I just want to show you a few things. So we have different battery capacities. So some devices have 18 hours, others have 45 hours. The price is different between each devices, and they can have limitations. For example, this watch can detect arrhythmias when between the range of 50 to 120. So when the heart rate goes up, it cannot analyze the tracing. It just gives you the heart rate, but it cannot analyze or interpret if you have atrial fibrillation or it's a sinus rhythm. While other types of watches will have ranges of between 50 to 150, some have ranges between 50 to 100. So we have a lot of variabilities between these watches. So all of these devices and technology and new machines, they should be connected to an infrastructure. So we need to have connectivity, secure networks, and cloud-based system in order to store all this data and to transfer all this data to the healthcare doctor and nurse. So we need to put this system. You can see here is a patient. He is connecting to sensors, and these informations are transmitted to a concentrator, which is a device that will store informations in a cloudlet. So the information will be transferred to the doctor by the internet, and the doctor will be able to visualize all this information and analyze the information and give his report. So it's a complex system. The patient is in the center. The patient is connected to the machines, to the sensors. You have data concentration, and we need to store all this information and transfer them to the doctor. We need to have also alert mechanisms because as all of these technologies, they have alert mechanism to notify the healthcare provider for critical changes in a patient's health condition. So we need to have this alert mechanism. For example, if the heart rate goes very high, we need to have an alert system to notify the patient and his doctor. It will allow for intervention. For example, we can add a medication to drop the heart rate or to drop the blood pressure, and we can avoid complications by incorporating alert mechanisms. So here is an illustration of this. You can see we have alarms attached to the patients, and all the information are transferred to the clinic or to the doctor, so the doctor can analyze these alarms. So why do we have these technologies, these alarms incorporated? Because all of this will allow us to early detect the health issues. For example, if the patient is having asymptomatic arrhythmias, when we have the device will record this arrhythmia, and we can diagnose it earlier than expected. So before these devices, we had a delay. When we have delay to diagnosis, for the diagnosis, we can have increased risk of complications. So by continuous monitoring, this will provide us a comprehensive understanding of patient health, enabling personalized care plans, and most importantly, we reduce the complications by early detection of the disease. So also, all of these technologies, it will break down geographic barriers, so all patients will be allowed to receive care regardless of their location. So here we're talking about telemedicine and remote patient monitoring, all of these technologies. Even if the patient is in a rural area, there is no hospital, there is no doctor, the patient can have access to healthcare by acquiring these technologies. Patients will be more engaged, as we said. The patient will understand their condition more and more. They understand why we are treating them, and they will be more compliant and they will adhere to their treatment plans, and they will adhere also to the lifestyle modifications because they are more involved in the decision making of their diseases. Cost saving also is very important because we said a lot of conditions can be treated without going to the emergency department. We can avoid emergency department waiting times. We can avoid spending in the emergency department. So we can save a lot of money. We can improve the economy. So we need to add these technologies. They cost a lot in the beginning, but on the long term, when we start to drop the complication rate, we will have economical benefits as well in the healthcare. Patients will be more satisfied because, as we said, they actively participate in their care and they understand more and more their diseases. Okay. Post-operative patients also can benefit from these technologies, mainly for remote monitoring. We can discharge them earlier than expected, so there is no need to keep the patient for 7 or 10 days. We can discharge them, for example, on the third or fourth day, and we can keep monitoring their vital signs, their heart rate, their blood pressure. If the heart rate goes up and the blood pressure goes down, in that case, we need to suspect bleeding because bleeding is common in the post-operative settings. So measuring vital signs remotely after the surgery is also a possibility. Now we will talk a bit about the usage of technology in specific conditions. So I will give you a few examples, and we will start by talking about the usage of technology in the case of heart failure. So as you know, that in case of heart failure, the heart, you can see the heart will become enlarged as compared to the normal heart. So the heart will not be able to pump the required amount of blood to the systemic organs. So we will have swollen and cyanotic foot because less blood is reaching the extremities. That's why we have cyanotic foots. And they become swollen because the venous return is altered because the heart is failing. So blood will accumulate here in the venous system. The blood will accumulate in the lung and in the stomach. So we'll have distended abdomen due to ascites. You can have fluid in the lungs, so pulmonary edema. You can have also swollen legs. So all of these are symptoms of heart failure. Heart failure can also be divided based on the ejection fraction percentage. So let's say a patient has an ejection fraction of 30%. We call it heart failure with reduced ejection fraction, half ref. So this category. Also, we can have a heart failure with mildly reduced EF, so heart EF between 41 to 49%, and heart failure with preserved ejection fraction when the ejection fraction is above 50%. So all of this is the most important classification by ejection fraction. Okay, so we said the symptoms because we have fluid in the lungs. We'll have shortness of breath, so dyspnea, shortness of breath. The patient will be tired. We'll have swollen ankles, so swollen legs. Loss of appetite because less blood is reaching the brain and the GI system, so we'll have less appetite. The patient will start coughing because of his fluid accumulating in his lungs. The dizziness, also dizziness because we have less blood reaching the brain, so we'll have dizziness, vertigo. Abdominal bloating because we have a lot of fluid accumulating in the abdomen, so we have ascites due to the heart failure, and sleep disturbances as well due to the stress, the anxiety from this condition, so it will lead to sleep disturbances. So what is the role of technology in case of how can we use technology in these patients? A way to do it is to insert a device. So these are new trials. We don't have these devices available for everyone, but there's development of devices that can measure the pulmonary artery pressure waveform. So when the pulmonary artery pressure is high, it means that the patient is overloaded because we have excessive fluid. And when the pulmonary pressure is lower, so it means that the patient is having a less fluid overload. If you see here on the PA systolic pressure curve on the blue one, you can see that the pressure is increasing in peaks. So here, when the device detects this increase in peak, the doctor will be notified and the doctor will tell the patient to increase his diuretic dose. So when we detect these increases in PA pressure, this will allow us to increase the diuresis, the diuretic dose. And you can see when we increase the diuretic dose progressively, the PA pressure has dropped in the next following months. So it's very important to detect these peaks, because when we have these peaks, we need to increase the diuretic dose in order to drop the circulating volume. And in that case, we decrease the heart failure symptoms. The patient will be more satisfied. The shortness of breath will decrease, the swelling of his limbs will decrease, and his abdominal distension will also decrease. So it's very important to start thinking about these technological advances. So this device is not currently recommended as class 1. It's class 2B in the guidelines, so we don't have a lot of data yet. We need more and more studies, but for sure in the next few years, such similar devices will be widely used because of the mortality benefit and the symptoms benefit in case of patients with heart failure. Another tools, we can have this kind of this application. For example, the patient will note each day his heart rate, his symptoms, the time when he noted these data, the blood pressure, and the weight. The next day, he will do the same at the same time. So the symptoms, the heart rate, the blood pressure, and the weight. You can see the first day he has a weight of 156. The second day he has a weight of 159. This is not in kilograms in LBS, so but you can see there is an increase in weight. So all of these data will be transferred to a triage system. So the data will be received by the Medley nurse coordinator. The Medley nurse coordinator will analyze this data, and in this case, this nurse will send an alert email to this cardiologist, and the cardiologist will then contact the patient in order to increase his diuretic dose, because an increase in weight in patients means patients with heart failure means that the patient is overloaded. So we need sometimes to see the patients, or we need to ask him to try to increase his diuretic dose and to remeasure his weight on the following day. So this application is very helpful. We can recommend it to our patients. It's very easy to use, and it's very effective also. So we have a lot of devices. We need to tell the patient to measure the weight, to take his vital signs daily. We have devices that can detect volume overload or lung congestion. So these devices are not very frequently used, but they are currently under development, and they will start using them in the next 5 to 10 years. So now we finished with heart failure and technology in heart failure. We will talk about the usage of technology in the settings of sleep apnea. So as you know, sleep apnea is a condition where we will have obstruction of the airways during sleep. We can have anatomic factors, and we can have also central factors. So most commonly, it's due to the blocked airway from anatomical factors. So the patient will snore at night. So it will be the patient will snore all night. It's associated with depression, with diabetes, because we said in the first presentation that sleep quality and duration is associated with hyperglycemia if less than 7 hours. It can lead to heart failure on the long term, high blood pressure also, and concentration problems during the next day because of his bad sleep quality. So he will have concentration problems. So it's either due to anatomical variation, it will not go on its own. So we need to add a machine, we call it CPAP, so continuous positive airway pressure therapy. It will always give him a pressure, mainly during expiration, to avoid the airway collapse. It's a very effective tool to treat sleep apnea. And in case of anatomical problems, we can offer the patient jaw surgery. Sometimes the condition can be related to allergies, so obstruction or of nasal cavities or upper respiratory tract due to allergies. So we can treat this allergy, and you always have to advise them to lose weight because weight loss also is associated with uh, improvement of symptoms because we decrease the fat around his neck and around his airways, so it will improve the situation. So how can we use technology in such cases? So telemedicine and telemonitoring here is very important for these patients. The information will be stored in a cloud, and this information will be transferred to the doctor and to the healthcare worker, and then they can have a triage system. These technologies, for example, in this study, you can see that these telemonitoring tools let us know how many hours the patient is using the CPAP machine, for example. So this patient has used this machine in the last 15 days. He used it 14 days, so 14 out of 15 days, which is very good. He used it more than 4 hours in 12 days and less than 4 hours in just 2 days. And the average usage time is 5 hours 41 minutes, which is also a good amount of usage. And you can see that it gives us an idea also about the leaks. So if the device is leaking, it means that the mask that we're putting is small or it's not very well fixed. It gives us an idea of how many apnea episodes the patient is having. So all of these data are very important in order to modify the settings of the machine or to change his mask or to attach it more properly. It's very important for sleep apnea for the patient to be compliant with the device because it's a device that most patients don't like to use. But you just always need to monitor all of these parameters to see if the patient is being well treated. Here also another device. It gave us an idea of the average usage, which is 8 hours for this patient. So he is having 57.9 apnea hypopnea index on average. It will tell you for each day how many hours he used. So for example, this patient on this date he didn't use it a lot. So we need to ask him about why he didn't use it, if there is any problem. So this monitoring will allow us to better control our patients. Same here as another patient, so it gives us an idea about the usage, how many hours. You can see on this day he didn't use it at all. The leaks, we can have variation of leaks. So each day we have an amount of leaks, so air is going out of the machine from the mask, so the mask is not attached properly in general. Most importantly, it will give us the idea about the AHI, so apnea hypopnea index, because when we give this machine, we expect not to have a lot of apnea hypopnea index because we are currently giving him this positive pressure. So we expect not to have such apnea hypopnea index level. So you can see that monitoring and technology in heart failure and apnea, sleep apnea are very important to follow up our patients. Now we have just a few slides remaining. We will talk about the usage of technology and the remote monitoring in patients with chronic kidney disease. So you know that chronic kidney disease is frequent. It's associated with hypertension and with diabetes, like we discussed in the first lecture today. You can see here we have a normal kidney, and here is a microscopic evaluation of this kidney. You can see we have the intact glomeruli and intact collecting tubules without fibrosis, without fat streaking. So it's a normal, healthy kidney. As compared to the kidney on the right, you can see this kidney is damaged. So it's a chronic kidney disease kidney. You can see there is a scar tissue, there is damaged glomeruli, and there is damaged tubules. So a typical kidney has 1 million filtering units. And when we have kidney damage, this filtering unit number will drop. So mainly as a relation to blood pressure and diabetes, as we said. So these filtering units will be reduced and they will be replaced by scar tissues. So the symptoms, they can have dry and itchy skin, they can be tired, weak, bubbly or foamy pee, urine. This means that we have a lot of proteins being lost in the urine, so the urine will become bubbly or foamy. They will become swollen extremities because also when we lose proteins in the urine, we will lose oncotic pressure in our vessels. So when we lose the oncotic pressures, the fluid will go out of the vessel to the interstitial space. That's why we have peripheral edema in cases of chronic kidney disease and proteinuria. Puffy eyes as well, will have edema around the eyes, trouble sleeping due to the anxiety of this condition, loss of appetite, muscle cramps. So all of these conditions, some symptoms are not specific, like tiredness or loss of appetite or trouble speaking, but we have specific symptoms like bubbly or foamy urine, swelling, and puffy eyes. So CKD also can be classified based on the creatinine clearance level. So you see stage 1 CKD is when we have a clearance of 90 and above. So this is a normal condition, or it can be due to mild kidney damage, but usually the kidneys here are working normally. When the clearance drops, the stage will go up. So when it becomes less than 15, in that case, we have a stage 5 chronic kidney disease. So we have a severely kidney damaged, and the kidneys here are very close to not working, or they already stopped working. So in that case, when we reach this stage, we need to start preparing the patient to undergo dialysis, because here the kidneys are not filtering the urine, and the toxins are being accumulated in the bloodstream. So how dialysis is performed. So as you see the patient here, we have the patient is linked to the machine. So the machine will filter the toxins from his blood, and the machine will give him back the filtered blood. So this machine is replacing the kidneys by filtering the toxic substances. And you can see they apply technology to follow up these patients. So when the patient is at home after doing the dialysis, they performed remote patient monitoring for them. You can see the red curve here is for patients that got surveillance at home or remote monitoring or telemetry, and the curve that is black and point curve in black here are the patients that did not receive the technologies and remote patient monitoring. So you can see that the patients that did not receive remote patient monitoring, they had higher incidence of events and mortality. You can see the curve is associated 10% of mortality at 12 months for patients that are on dialysis, as compared to just maybe 2 or 3% percentage of events or mortality in patients that received remote patient monitoring, and they used all this technology to monitor them when they are out of the hospital at 12 months. So we have very significant decrease in mortality in this study. This study was published in November 2023, so it's very recent study on the impact of remote monitoring on standardized outcomes in nephrology peritoneal dialysis. So these patients were on peritoneal dialysis, not on hemodialysis, but the outcomes are similar. We have drop in mortality and drop in adverse event at 12 months in patients that uses the technology, and in patients that are remotely monitored. So it's very beneficial for such patients. Last, we will talk about the usage of technology and remote monitoring also in patients that are diabetics. So we already said that we have three types of diabetes. We have the type 1, which is an autoimmune disease. We already said we have antibodies circulating in the circulation. These antibodies will go attack the beta cell of the pancreas. So we won't have production of insulin. We need to start giving them insulin at diagnosis. While type 2 diabetes are patients that have insulin, but they tend to have resistance to this insulin, so the body is not using the insulin properly. And we have the gestational one, which occurred just during pregnancy. It's due to genetic and environmental risk factors, but also we have insulin resistance in that case. We have insulin, but we have resistance during pregnancy. You need to know also that type 1 usually occurs in younger individuals, but type 2 is more frequent in older, and it's more frequent overall. It occurs in older, but nowadays we are seeing it more frequently even in younger patients due to the increasing in prevalence of diabetes, of obesity, sorry. So obesity is very correlated with type 2 diabetes. And we said that the normal hemoglobin A1C should be less than 5.7. When it's between 5.7 to 6.4, here we are in the pre-diabetes condition. We should start to act on the lifestyle here in order to delay the progression to diabetes. And when the hemoglobin A1C is above 6.5 or higher, so in that case, we have the diagnosis of diabetes that is confirmed. Same for the fasting glucose. So we said we should measure it in the morning before the meals. It should be less than 100 in normal patients. Pre-diabetes 100 to 125, and diabetes above or equal to 126. So A1C level of 6.5 and above, and fasting above 126, we can diagnose diabetes. So they did a very nice trial also about the usage of remote monitoring and technology to follow diabetes patients. And this study is about remote glucose monitoring for outpatients, for patients that are not hospitalized. So they ask these patients if they are satisfied with these technologies and these remote glucose monitoring technologies. You can see that 65% of patients in this study said that these tools are very helpful for them, and just 6% said that these tools are not helpful. And for them, the preferred method to do it is by text messaging. For example, they take their insulin level, for example, they take their glucose level, they then send a text message to the doctor or to the nurse that is following their case, and the doctor will tell them, for example, to increase the insulin dose or to decrease the insulin dose depending on the glucose level. And most of these patients, so 91%, said they use these communication tools in order to change the insulin dose. So, as we said, the most important part of this study, they found out that these patients use this method to modify their insulin dose, because if the glucose is higher, they need higher dosage, and if the glucose is dropping, it means that these patients are on a supratherapeutic dose of insulin, so the doctor will tell them to decrease the dose. And they also ask them if these tools cost them time or they lose time with this tool. 0%. So no patient said that they lost time while using these technologies. 65% said that there was no impact on time, so they didn't lose time, they didn't also gain time. And 35% said that they saved time because these patients, for example, they directly increase the insulin dose instead of just being lost, not knowing what to do. They directly receive the confirmation from the doctor on what insulin dose they should take. So it's a study that confirms that these technologies and these remote monitoring tools were very effective because all of these patients were satisfied by using it. And that was it about the usage of technology and remote patient monitoring in chronic diseases. If you have any questions,
صوت واضح؟ لو سمحتم. Hello, I'm Dr. Elisa. I'll be your host for this session. I will be speaking in English and Arabic. Okay, سأتكلم في الإنجليزية والعربية. كله تمام? Okay. So let's talk a little bit about the stroke in general from A to Z. Okay. So in this presentation, we will speak about the definition of stroke, clinical presentation, some types of stroke, goals of stroke care, and chain of survivals, the 8 Ds of stroke, special consideration, stroke rehabilitation from basics to advances. أوكي، المحاضرة مدتها ساعة ونصف، سنتكلم عن كل هذه التفاصيل. So the stroke is a neurological deficit, as you know, attributed to an acute focal injury of the CNS by a vascular cause. Cerebral infection, intracerebral hemorrhage also, and subarachnoid hemorrhage. The major cause of disability and death worldwide. So the stroke is a major cause of disability, as you know. Let's talk a little bit, first of all, about the transient ischemic attack. So it's a brief episode of neurological dysfunction resulting from focal cerebral ischemia, not associated with permanent cerebral infection. TIAs resolve spontaneously within 1 hour. إذن نتكلم هنا عن نوبة بجلطة العابرة والجلطة الدماغية السريعة أو الصغيرة، والتي هنا تعرف هذه النوبات أو الجلطات العابرة أحيانا بالجلطات التنبيهية. ومن المهم هنا أن نعلم أن هذه النوبة أو العابرة هي إشارة تحذيرية لجلطة دماغية مستقبلية أو حتى جلطات دماغية مستقبلية. ونوبة الجلطة العابرة هي حالة طبية طارئة تماما مثل الجلطة الدماغية الكبرى، ولا يوجد وسيلة لمعرفة في البداية ما إذا كانت الأعراض ناتجة عن نوبة الجلطة العابرة أو نوع رئيسي من الجلطة الدماغية. مثل الجلطات الدماغية العابرة غالبا ما تسبب التجلطات الدموية وغيرها. إذن أكثر من ثلثي الأشخاص الذين يعانون من نوبة الجلطة العابرة ولا يتلقون العلاج يعانون من جلطة دماغية، أو ممكن أن يحصل لهم جلطة دماغية كبرى خلال عام واحد. ويصاب ما بين 10% إلى 15% من الأشخاص بجلطة دماغية كبرى في غضون 3 أشهر من نوبة الجلطة العابرة اللي هي TIA. نوع الجلطة الدماغية in general, we have the hemorrhagic stroke and the ischemic stroke. Okay. So the ischemic stroke, it's 87% of the cases. Usually they are ischemic. 13% بيكونوا hemorrhagic. So الاسكيميك أو الجلطة الدماغية أو النشاف بما معناه، كما قلنا هي ناتجة عن النشاف أو تحدث هذه الجلطات أيضا عندما تسد الأوعية الدموية أو بجسيمات أو بالكلوتس، ويمكن أن تسبب أيضا الترسبات الدهنية المعروفة بالصفائح أيضا تسبب انسداد في الأوعية الدموية من خلال تراكمها فيها. أما الجلطة الدماغية النسفية الهيموراجيك، تحدث الجلطة هذه الجلطة النسفية عندما يتسرب الدم أو يكون لدينا نزيف في الدماغ أو ينفجر أو ينفتح الشريان، وهنا يضخ الدم المتسرب ويشكل ضغطا زائدا على الخلايا الدماغية مما يضر بها. عادة ارتفاع ضغط الدم والأوعية الدموية وهو أحد وضعف الأوعية الدموية وبروز في الأوعية الدموية بروز شكل البالون أو ما يشبه البالون في الشريان يمكن أن ينفجر أيضا ويشكل هذا النزيف. Okay. Let's go a little bit to speak about the clinical presentation. Okay. إذا كان الشخص عم يحصل له جلطة دماغية نسفية أو جلطة دماغية بشكل عام، ما هي العوارض الكلينيكية أو السريرية؟ headache, confusion, abnormal vision, abnormal speech, weakness, numbness on one side of the body, loss of balance, inability to walk. Okay, لازم نحفظ, we have to really keep in mind this word face, okay, or fast, which means face, A for arm, S for speech, and T for time. سنشرح. Okay. The Cincinnati pre-hospital stroke scale as a quick assessment. Okay. هو like إذا أردنا هو تشخيص سريع للمريض أو للشخص الذي هو أمامنا إذا كان يحصل له أو يعاني من سكتة دماغية سريعة. إذا مقياس سنسيتي للسكتة الدماغية هو نظام يستخدم لتشخيص السكتة الدماغية المحتملة في قبل الوصول إلى المستشفى، في البيت، في العمل، إلى آخره. وهو يختبر 3 علامات لاكتشاف النتائج غير الطبيعية أو العوارض الغير طبيعية التي قد تشير إلى إمكانية حدوث سكتة دماغية لدى المريض. إذا كانت أي واحدة من هذه العوارض ال3 ظاهرة فمعناه أن هنالك شيء غير طبيعي يحصل لدى المريض، فقد يكون المريض هنا يعاني من سكتة دماغية ويجب نقله إلى المستشفى في أقرب وقت ممكن. Okay, starting with the facial draw, have patient show teeth or smile. Okay, ترهل في الوجه. هنا نطلب من الشخص أن يبتسم أو يظهر أسنانه. إذا لم يتحرك جانب واحد بنفس القدر كما يتحرك الجانب الآخر فقد يكون ذلك علامة على وجود سكتة دماغية. قد يكون. الوضع الطبيعي هنا في ترهل الوجه، الوضع الطبيعي إذا طلبنا من المريض أن يبتسم تتحرك كلا الجانبين من الوجه بنفس القدر. الوضع الغير طبيعي abnormal, one side of face does not move as well as the other side. إذا لا يتحرك أحد الجانبين من الوجه بنفس القدر. النقطة الثانية arm drift. Patient close eyes and hold both arms out for 10 seconds. نطلب من الشخص أن يغلق عينيه ويمد ذراعيه مستقيمين أمامه والكف يواجه الأعلى، كف اليد إلى الأعلى لمدة 10 ثوان تقريبا. إذا لم تتحرك أحد الذراعين أو إذا تحركت أحد الذراعين للأسفل أكثر من الجانب الآخر فقد يكون ذلك علامة على سكتة دماغ. The normal, both arms move to the same or both arms do not move at all. The abnormal, one arm does not move or drift down compared to the other. إذا الطبيعي، الوضع الطبيعي أن تتحرك كلا ذراعين بنفس القدر أو لا تتحرك على الإطلاق. الوضع الغير طبيعي لا تتحرك أحد الذراعين أو ينحرف أحدهما للأسفل بالمقارنة مع الجانب الآخر. The third point, abnormal speech. So have the patient say, you can teach an old dog new tricks, for example. Okay, نطلب من الشخص أن يقول أي جملة بسيطة. Okay. يعني نطلب منه أن يقول كما قلنا عبارة بسيطة أو مألوفة لديه. إذا كان الشخص ينطق الكلمات بصعوبة أو يخطئ في بعض الكلمات أو يكون غير قادر على الكلام قد يكون ذلك علامة على سكتة دماغ. So, the normal patient uses correct words with no slurring. إذا الوضع الطبيعي المريض يستخدم الكلمات الصحيحة دون تململ ودون خطأ. Abnormal الوضع الغير طبيعي patient slurs words, uses the wrong words or is unable to speak. إذا التململ في الكلمات أو استخدام كلمات غير مناسبة أو عدم القدرة على الكلام. إذا المرضى here we should say that if any one of these 3 signs is abnormal, the probability of a stroke is 72%. If the 3 signs are there, probability is 85%. إذا المرضى الذي يظهر لديهم واحدة من هذه العلامات، واحدة من هذه ال3 علامات، لديهم احتمالية 72% 72% من وجود جلطة دماغية. أما إذا كانت العلامات ال3 موجودة فإن الاحتمالية ترتفع أو تتجاوز 85%. تمام؟ واضح؟ Okay, time is brain. We should really keep this in mind. Time is brain. In a typical acute ischemic stroke, every minute under reperfusion, the brain loses 1.9 million neurons, 14 billion synapses, 7.5 miles of myelinated fibers. Okay? كل دقيقة من التأخير في العلاج، كل دقيقة من التأخير في العلاج يفقد الدماغ 1.9 مليون من النيورونز، 14 بليون مليار من السينابسز، 7.5 مايلز من myelinated fibers. اوكي، وهذه دراسة بناء على دراسة سيفر ستروك 2006. Okay, let's speak a little bit about the D's of stroke care, the 8 D's of stroke care. Okay, we have the detection, dispatch, delivery, door, data, decision, drug, and disposition. Starting with the detection, it's a rapid recognition of stroke symptoms. إذن الكشف detection يتضمن هذا الكشف التعرف سريع على أعراض السكتة الدماغية، وتشمل الأعراض المبكرة للسكتة الدماغية، الضعف والخدر الوجه أو الذراع أو الساق، وبطبيعة الحال في جانب واحد من الجسم، وتشمل أيضا العلامات والأعراض الأخرى كالارتباك وصعوبة البلع وعدم القدرة على البلع وصعوبة في الرؤية أو المشي، الدوار أو الدوخة، والصداع الحاد المفاجئ بدون سبب محدد. وهنا يجب القول أن الكشف السريع والمبكر والتعرف على أعراض السكتة الدماغية يساعد على تنفيذ التدخلات الطبية المناسبة ويحسن من الأوتكمز أو النتائج الجيدة للمرضى. Dispatch التوزيع early activation and dispatch of EMSS by calling etc. يشمل الإرسال هذا أو تنشيط خدمات الطوارئ في وقت المبكر. يتم إذا هنا يجب علينا القول أن يتم نقل نصف مرضى السكتة الدماغية إلى وحدة الطوارئ بواسطة أفراد العائلة أو الأصدقاء. عادة الدراسات بيّنت أن يتم نقل تقريبا نصف مرضى السكتة الدماغية إلى الوحدة بواسطة أفراد العائلة أو الأصدقاء، وهذا هذا يمنع إعداد أو تحضير وحدة الطوارئ أو تحضر لاستقبال المريض، وأن يكون الأطباء جاهزون لوضع الأنظمة المناسبة للعلاج. وهنا يجب تدريب وطلب أو تدريب العائلة والأصدقاء لطلب الإسعافات الطبية وإرسال سيارات الإسعاف لنقل المريض إلى الطوارئ، وبذلك يمكن الإسعافات الطبية أن تتصل أو عليها أن تتصل بوحدة الطوارئ وتبليغها أنها لديهم مريض يعاني من سكتة دماغية وعليهم التحضر وأن يكونوا على استعداد. Delivery النقل. So it's a rapid EMS identification management and transport. إذا النقل هو نقل المريض بسرعة إلى المستشفى. يفضل أن يكون مستشفى متعلق بالعلاج الأمراض العصبية أو مرض الجهاز العصبي، ويجب تدريب الكوادر الطبية هنا على إجراء تقييم سريع لحالة المريض. إذا كانت هناك شكوك في وجود سكتة دماغية يجب نقل المريض إلى المستشفى المناسب في أقرب وقت ممكن. وأيضا في هذه الحالة يجب توثيق التاريخ والوقت، التاريخ الطبي والحالة العقلية الأساسية للمريض، ويجب أيضا تسجيل الوقت منذ بدء الأعراض ويشار إليه بالوقت 0 تايم 0 أو آخر مرة شوهد فيها المريض على أنه في وضع طبيعي. وما السبب هنا؟ يحتاج العاملون في المجال الطبي الطارئ إلى تقديم معلومات قبل الوصول إلى المرفق الذي المستلم أو الديستنيشن، حتى يتمكن الأشخاص في وحدة الطوارئ من الاستعداد لوصول هذا المريض وإجراء اللازم. دور appropriate triage to stroke center. إذا هنا يشير هذه المقطع إلى وصول المريض إلى وحدة الطوارئ في الواقع، ويجب أن يكون كما قلنا فريق الطوارئ في أو فريق الستروك في المكان المناسب قبل وصول المريض لضمان التقييم والتشخيص السريع والفوري. إذا وفقا لتوصيات المعهد الوطني هنا لاضطرابات الأمراض الجهاز العصبي، يجب أن يكتمل التقييم من قبل طبيب الطوارئ في غضون 10 دقائق من وصول المريض إلى وحدة الطوارئ، في غضون 10 دقائق. داتا البيانات appropriate triage to stroke center. إذا هنا جمع البيانات هو جزء أساسي من سلسلة النجاة. يعد السيتي أو السيتي سكان أداة أساسية مطلوبة لتشخيص الدقيق، ويجب إجراء هذا الفحص بدون تباين للتفريق بين السكتة الدماغية والنزفية وإلى آخره، إذا كانت تنخرية أو نزفية، يعني نشاف أم نزف. ويجب إكمال الفحص بواسطة السكان في غضون 25 دقيقة من وصول المريض إلى وحدة الطوارئ، ويجب أن يتم قراءته في غضون 45 دقيقة من الوصول إلى وحدة الطوارئ. يعني في غضون أقل من ساعة يجب علينا أن نفحص المريض وأن نقوم بتصويره عبر السكان ووضع حتى وضع الريبورت وقراءته. القرار decision stroke expertise and therapy selection. هنا القرار بشأن نوع العلاج المطلوب هو الخطوة التالية في رعاية مريض السكتة الدماغية. يتم هنا النظر في المعلومات مثل نوع السكتة التي حدثت والوقت من بدء الأعراض قبل اتخاذ قرار بشأن العلاج. وعلينا هنا أن نشير أن شدة السكتة تلعب دورا أساسيا في اتخاذ القرار، قرار المعالجة الأنسب. ويجب أيضا هنا إبلاغ المريض وأفراد الأسرة بالمخاطر والفوائد المتعلقة بخيارات العلاج، ويجب تفسير تقنيات التصوير والإضافية مثل الMRI وإلى آخره. يجب أن نشرح ونفسر للمرضى الذين يشتبه في إصابتهم بسكتة دماغية، ويجب إجراء هذه الأشعة بسرعة من قبل طبيب ماهر ولديه خبرة في تفسير الصور العصبية أو الصور المتعلقة بهذه الحالة. Drug fibrinolytic therapy intra-arterial strategy. الدواء بشكل عام، إدارة الدواء إذا كان مناسبا هو الرابط التالي في سلسلة النجاة. إذا كان المريض مؤهلا للعلاج الفايبروناليتيك فإن الفترة الزمنية المتاحة للإدارة ضيقة، ليس لدينا رفاهية الوقت هنا. إذا وفقا للمبادئ التوجيهية لجمعية القلب الأمريكية يجب إعطاء العلاج الفايبروناليتيك في غضون 3 ساعات من بدء الأعراض، أن لا يتعدى 3 ساعات، وسنرى فيما بعد بالتفصيل ذلك. إذا لم يكن المريض مؤهلا للعلاج الدوائي فقد يكون مؤهلا للعلاج الوعائي لإزالة الجلطة ميكانيكيا بدل من العلاج الدوائي. التصرف so disposition rapid admission to stroke unit ICU. هنا هذه الخطوة في رعاية السكتة الدماغية تركز على الرعاية المستمرة لمريض السكتة الدماغية. يوصى هنا بأن يتم نقل المريض إلى وحدة الرعاية المركزة أو إلى وحدة الستروك أو السكتة الدماغية في غضون 3 ساعات من وصولهم إلى وحدة الطوارئ. تستمر المراقبة هنا والرعاية المستمرة لمريض الستروك في تقييم ومتكرر ودائم للحالة، ومراقبة مستويات الجلوكوز والعلامات الحيوية، وكذلك الوقاية من المضاعفات. تمام؟ واضح؟ عفوا. اوكي. suspected stroke algorithm. اوكي، لدينا هو خوارزمية تتعلق بالاشتباه في السكتة الدماغية. Identify signs and symptoms of possible stroke, activate emergency response. أولا تحديد علامات وأعراض احتمال السكتة الدماغية وتنشيط الاستجابة الطارئة. كما قلنا أن نستخدم السنسينيتي أو الفاست اللي هي علامات الإنذار مثل انحناء الوجه وضعف الذراع وصعوبات في النطق كما قلنا. هنا نحدد علامات وأعراض احتمال السكتة الدماغية. أوكي. Then critical EMS assessment and actions. Support ABCs, give oxygen if needed, perform pre-hospital stroke assessment, establish time of symptoms onset, triage to stroke center, alert hospital, check glucose if possible. في المرحلة الثانية تقييمات وإجراءات الطوارئ الحرجة. توفير الأكسجين للمريض إذا لزم الأمر، إجراء تقييم مسبق للسكتة الدماغية في الإسعاف، تحديد وقت بدء السكتة الدماغية، وتقييم المريض لنقله إلى مركز ستروك مع إبلاغ المستشفى مسبقا لتفعيل الستروك تيم أو الفريق السكتة الدماغية ليكون بجهوزية تامة. 3. Immediate general assessment and stabilization. Assess ABC's vital signs, provide oxygen if hypoxemic, obtain IV access, check glucose, perform neurologic screening assessment, activate stroke team, and order emergent CT scan or MRI of brain, obtain 12 lead ECG. إذا تقييم عام فوري هنا ولتثبيت والتأكد من الحالة. بمجرد وصول المريض إلى وحدة الطوارئ وفي غضون 10 دقائق من الوصول، علينا القيام بتقييم العلامات الحيوية وتوفير الأكسجين إذا كان المريض يعاني من نقص الأكسجين. الحصول أيضا على وضع الاي في، يكون لدينا اي في اكسس، اجراء الفحوصات التدريبيه وفحص الجلوكوز وتنشيط فريق السكتة الدماغية، وأيضا في هذه المرحلة إجراء فحص عصبي باستخدام السي تي سكان أو الام ار اي، والحصول أيضا على نتائج اي سي جي. اوكي. في المرحلة الرابعة immediate neurologic assessment by stroke team or designer, review patient history, establish time of symptoms onset or last known normal, perform neurologic examination. في هذه المرحلة علينا القيام بتقييم عصبي فوري بواسطة فريق الستروك أو المتخصصين. إذا هنا في غضون 25 دقيقة من وصول المريض إلى وحدة الطوارئ، يجب على الفريق أو المتخصصين أن يستعرض تاريخ المريض ويقوم بتحديد جدول زمني لظهور الأعراض، وأيضا يقوم بالفحص العصبي باستخدام مقياس سكتة الدماغ الوطني أو مقياس العصبي etc. في المرحلة الخامسة هنا نسأل does CT scan show hemorrhage؟ هل يظهر فحص السي تي سكان وجود نزيف؟ وهنا علينا تحديد ما إذا كان الاسكان يظهر وجود نزف في غضون 45 دقيقة كما قلنا قبل من وصول المريض إلى وحدة الطوارئ. إذا لدينا 45 دقيقة لتأكد من وجود نزيف أم عدم وجود نزيف، أو هي سكتة تتعلق بالنشاف أو التخثر. احتمالية حدوث سكتة دماغية تحتاج للعلاج بالفايبرونيليتيك. اوكي. اذا المرحلة السادسة اذا لم يظهر فحص السكان اي علامة تدل على نزيف، فمن المحتمل ان المريض يعاني من سكتة دماغية تحتاج لعلاج بالفايبرونيليتيك. نتحقق هنا من استثناءات الفايبرونيليتيك مثل إصابة الرأس بضربة قوية أو سكتة دماغية في ال3 أشهر السابقة، أو وجود تاريخ لدى المريض بالنزف نزف داخلي في الجمجمة أو ارتفاع ضغط الدم ونزيف داخلي نشط أو أي تركيز للجلوكوز في الدم أقل من 50 ملغ بالديسيليتر. وأيضا نكرر الفحص العصبي. في المرحلة السابعة we administer، إذا نعطي administer aspirin. The patient remain candidate for fibrinolytic therapy. If not a candidate, we give aspirin. If candidate كما قلنا نعمل كل البروسيجر في إعطاء الفايبرونيليتيك. إذا هنا ننتقل إلى begin stroke or hemorrhage pathway, admit to stroke unit or intensive care. إذا نعطي الأسبرين في حال لم يكن المريض مرشحا للعلاج بالفايبرونيليتيك، نعطي الأسبرين ونبدأ مسار السكتة الدماغية أو النزيف. هذا المسار هو بقبول المريض في وحدة السكتة الدماغية ووحدة الرعاية، ونبدأ في العلاج الطبي والعلاج الفيزيائي. اوكي، هذا بشكل عام. اوكي. اوكي. Here we're going to talk a little bit about the scales. المقاييس التي نستعملها لمعرفة مدى إصابة المريض أو مدى أهمية إصابة المريض. So so the Bartle Scale Index is an ordinal scale used to measure performance and activity of daily living. 10 variables describing ADL and mobility are scored, a higher number being a reflection of greater ability to function independently following hospital discharge. Okay. So the Bartle scale intended population, stroke, neuromuscular or musculoskeletal disorder, so patient with stroke, neuromuscular or musculoskeletal disorder, and oncology patients فينا نطبق عليهم بارتل سكيل لمعرفة إذا مقياس بارتل بشكل عام هو مقياس تسلسلي يستخدم لقياس الأداء في أنشطة الحياة اليومية. وهنا يتم تسجيل عادة 10 متغيرات أو 10 مقاييس في الأنشطة اليومية وقدرة على التنقل، ويعكس الرقم الأعلى كما قلنا قدرة أكبر على القيام بالوظائف بشكل مستقل بعد خروج المريض من المستشفى. وهنا يتم استخدام الوقت المستغرق والمساعدة الجسدية المطلوبة لأداء كل بند في تحديد القيمة المعينة لكل بند. وهنا يقيس مؤشر بارتيل درجة المساعدة المطلوبة من الفرد في 10 بنود متعلقة بالقدرة على التنقل ورعاية الذات في الحياة اليومية. أوكي. طريقة الاستعمال. أوكي. Direct observation 20 minutes. Time may vary depending on client tolerance and ability. Okay. Includes 10 personal activities: feeding, personal toileting, bathing, dressing and undressing, getting on and off a toilet, controlling bladder, controlling bowel, moving from wheelchair to bed and returning, walking on level surface or propelling a wheelchair if unable to walk, and ascending and descending stairs. إذا الوقت المستغرق هنا لتطبيق البارتل سكيل هو تقريبا 20 دقيقة مراقبة مباشرة، وهنا قد تختلف الأوقات اعتمادا على تحمل الشخص وقدراته. وهنا يتطلب أكيد التدريب إذا تم تنفيذه بالمراقبة المباشرة، ثم تطويره في عدة أشكال، ويمكن تطبيقها في عدة حالات، ويمكن استخدام هذا التقييم على المدى الطويل. ويشمل مقياس بارتل كما قلنا 10 أنشطة شخصية للمريض، هي التغذية، استخدام المرحاض الشخصي، الاستحمام، اللبس والصعود والنزول من المرحاض، التحكم في المثانة، التحكم في الإمعاء، التحرك من الكرسي أو في الكرسي المتحرك إلى السرير والعكس، المشي على سطح مستوٍ، والصعود والنزول جرش. Okay, so each item is rated in terms of whether the patient can perform the task independently with some assistance or is dependent on help based on observation. So 0 is unable to do it, 1 needs help, 2 independent. Okay, so the final score is times 5 to get a number on a 10, on a 100, sorry, point score. So scores of 0 to 20 indicates total dependency. إذا نحن التقييم هنا بشكل يتم التقييم هنا بشكل يتعلق بما إذا كان المريض قادرا على أداء المهمة بشكل مستقل مع بعض المساعدة، أو هو يعتمد على المساعدة بناء على المراقبة إلى آخره. إذا 0 هو غير قادر على القيام بالمهمة، 1 يحتاج إلى مساعدة، 2 مستقل تماما. وهنا يتم احتساب النقاط بضرب 5 للحصول على رقم على مقياس 100. إذا هنا الإرشادات المقترحة لتفسير هذه النتائج هي أن درجات تتراوح من 0 to 20 indicates total dependency. Okay. تبعية كلية، يعني بحاجة لمساعدة. 21 to 60 indicate severe dependency. من 21 إلى 60 تشير إلى بحاجة لمساعدة شديدة. من 61 إلى 90 indicates moderate dependency. أوكي، بحاجة إلى مساعدة معتدلة. From 91 to 99 بحاجة إلى slight dependency أو مساعدة طفيفة. يستخدم معظم الدراسات أو نقطة القطع 61 ملاحظة يجب عدم استخدام هنا مؤشر بارتيل بمفرده للتنبؤ بالنتائج، إذن علينا أن نستعمل عدة scales. Okay, so as we said, the index should be used as a record of what a patient does, not a record of what a patient could do. إذا نستعمل هذا الاندكس لنعرف ما قدرة المريض، ما يمكنه أن يفعل، وليس ما يمكنه أو ما لا يمكنه فعله أو تطبيقه. إذا the main aim is to establish degree of independence from any help, physical or verbal, however minor and for whatever reason. So the need for supervision renders the patient not independent. So a patient's performance should be established using the best available evidence, asking the patient. Okay, let's move now to the modified ranking or Rankin scale. So the modified Rankin scale, MRS, is a commonly used scale for measuring the degree of disability or dependence in the daily activities of people who have suffered a stroke or other causes of neurological disability. It has become the most widely used clinical outcomes measure for stroke clinical trials. إذن مقياس رانكن المعدل هو مقياس تصنيف شامل لنتائج المرضى بعد السكتة الدماغية، يستخدم لتصنيف مستوى الاستقلالية كما قلنا الوظيفية بالإشارة إلى الأنشطة قبل السكتة الدماغية بدلا من الأداء المراقب المهمة محددة. So you have the score from 0 to 6. As per definition, 0 is no symptoms, 1 no significant disability, able to carry out all usual activity despite some symptoms. يعني 0 ما عنده ولا أي مشكلة. 1 no significant disability وممكن أن يقوم بالactivities العادية. Slight disability for the score 2, for the score 3 moderate disability, 4 moderately severe disability, 5 severe disability, and 6 death. اوكي، اذا الطريقه هنا التقليديه للتنفيذ المقياس رانكن المعدل هي عمليه مقابله وموجهه. يتم هنا تنفيذ تقييم عن طريق سؤال المريض عن انشطته اليوميه كما قلنا، بما في ذلك الانشطه الخارجيه، ويجب الحصول على معلومات حول العوائق العصبيه للمريض في خلال الفحص، بما في ذلك فقدان القدرة على التحدث والعواقب الفكرية. ويجب أن تدمج جميع جوانب الأداء الجسدي والعقلي واللفظي للمريض في اختيار درجة مفردة واحدة من مقياس رانكن المعدل. Okay, so a score of 0 to 3 في modified Rankin scale, so 0 to 3 indicate mild to moderate disability, and a score of 4 to 5 indicates severe disability. Time of this of this scale is 5 to 15 minutes. Okay, great. Allow me here to speak a little bit about the TPA for stroke أو العلاج أو علاج السكتة الدماغية بالبلاسمونيجين. Okay, so as per we cannot speak a little bit about definition, potential benefits, potential risk, and balancing benefits and risk and alternative. Okay, as per definition, الTPA هي المادة الفعالة المنشطة للتريبين والبلاسمونيجين، وهي دواء قوي لتذويب الجلطات. وكما نعرف هنا تحدث سكتة دماغية عندما يتم حرمان منطقة أو عدم وصول دم إلى أو الأكسجين بطبيعة الحال والمواد الغذائية إلى منطقة في الدماغ، وتعود الانسدادات المفاجئة إلى تجلط الدم ويمكن هذا أيضا أن يؤدي إلى فقدان الوظيفة في المنطقة المتأثرة من الدماغ كما نعرف. وتشمل العلامات والأعراض الشائعة للسكتة الدماغية كما البدء المفاجئ لضعف أو خدر في جانب الجسم الواحد كما قلنا فيما قبل. Okay. Potential benefits. الفائدة المحتملة. هنا يجب علينا الإشارة أن أشارت دراسة هنا في المعهد الوطني لاضطرابات الجهاز العصبي إلى أن 8 من بين 18 مريض بسكتة دماغية الذين يتلقون ال TPA وفقا لبروتوكول صارم سيتعافون بنسبة 3 أشهر، بحدود 3 أشهر بعد الإصابة دون إعاقة كبيرة. ويتم هنا مقارنة ذلك ب6 من بين 18 مريض بسكتة دماغية، يعني الذين يتعافون بشكل كبير بغض النظر عن العلاج. أوكي. إذن الأفضل أن نستعمل بطبيعة الحال النتيجة أفضل إذا استعملنا ال TPA. potential risk. المخاطر المحتملة لل TPA كما هو الحال مع معظم العلاجات هناك مخاطر مرتبطة بإعطاء TPA، وهنا تختلف الدراسات في توقع احتمالية الآثار الجانبية التي تشمل النزيف داخل الدماغ وأنواع أخرى من النزيف الخطير وإلى حد الوفاة. وهنا يجب الإشارة أيضا إلى so the balancing benefits and risk and alternative. موازنة المزايا والمخاطر هنا والبدائل. من المهم أن يقوم الأطباء والمرضى أو حتى أفراد العائلة بتقييم احتمالية الفائدة بما معناه تحسين الوظيفة بعد 3 أشهر أو الوظائف الحياتية مقابل احتمالية الضرر والذي هو النزيف الشديد أو الوفاة إذا أعطينا TPA. إذن الأعراض الناجمة عن السكتة الدماغية وحدها غير كافية لتشخيص السكتة الدماغية بشكل قطعي. وفي حالة المرضى الذين يعانون من محاكاة سكتة دماغية يؤدي استخدام TPA إلى آثار جانبية محتملة دون إمكانية الاستفادة. أوكي. contraindications. بطبيعة الحال هنالك تحذيرات أو we have the exclusion criteria and the relative exclusion criteria. تم هنا نشر عليه الإشارة إلى أن تم هنالك كما قلنا إذا معايير الاستبعاد هي إصابة في الرأس أو سكتة دماغية سابقة في غضون 3 أشهر السابقة. الأعراض التي تشير إلى وجود نزيف أو ثقب في الشريان في موقع غير قابل للضغط في الأيام ال7 السابقة. نزيف داخل الجمجمة سابق أو وجود ورم دماغي داخل الجمجمة أو توسع في الشرايين. جراحة في وقت سابق، جراحة في الجمجمة أو النخاع الشوكي. ارتفاع ضغط الدم، نزف داخلي، تخثر دموي حاد في استخدام الهيبارين في 48 ساعة السابقة، استخدام الأدوية المضادة للتجلط، استخدام مثبطات التروبين المباشرة، وأيضا تركيز الجلوكوز في الدم إذا كان أقل من 50 ملغ. وهنالك أيضا relative exclusion criteria أو تحذيرات نسبية. وهنا تشير التجارب إلى أنه في بعض الظروف بعد النظر والتدقيق في المخاطر ومقابل الفوائد يمكن للمرضى أن يتلقوا علاج الفايبرونيليتيك على الرغم من وجود تحذيرات نسبية واحدة أو أكثر. يعني سأعدد التحذيرات التي ممكن أن نعطي فيها علاج TPA ولكن under control. أعراض السكتة الدماغية، إذا كانت أعراض السكتة الدماغية طفيفة وقد تتحسن بسرعة، إذا كان هنالك من pregnancy حمل أو نوبة صرعية في بداية السكتة مع تأثيرات عصبية متبقية، جراحة كبيرة أو إصابة خطيرة في الفترة السابقة لمدة 14 يوم، نزف هضمي أو نوبة قلبية حادة. So let's move to okay, let's here speak about some studies. So patient treated with intravenous TPA, okay, المرضى الذي تعالجوا في TPA within the first 60 minutes of their stroke onset في فترة ساعة من حصول الستروك. The putative golden hour ما يعرف بالساعة الذهبية golden hour had significantly better outcomes at hospital discharge compared to patient treated just an hour later based on US data from more than 65,000 acute ischemic stroke patients. إذن الذين تلقوا العلاج في غضون ساعة كان لديهم outcomes جيد جدا عند خروجهم من المستشفى أو جيد أو أفضل عند خروجهم من المستشفى مقارنة بالأشخاص الذين تلقوا نفس العلاج لكن بتأخير ساعة، يعني في غضون ساعتين، اوكي، بين الساعة والساعتين from 61 to 120 minutes. In national US clinic practice, treatment with intravenous TPA in the golden hour, the first 60 minutes, compared with later, is associated with more frequent independent ambulation at discharge. So and discharge to home and freedom from disability or dependence at discharge compared with patient treated at 61 to 108 minutes according to researchers. إذن الأشخاص الذين تلقوا العلاج في الساعة الذهبية اللي first 60 minutes first hour compared with اللي تلقوا العلاج later في فترة اللي تتعدى الساعة ولا تتخطى 3 ساعات، أكيد كانت النتيجة أفضل من خلال الامبيليشن، تحركهم، المشي، استقلاليتهم وحريتهم في التحرك. Okay, so researchers of a multivariate analysis examining treatment outcome using intravenous TPA quickly from their stroke onset found that even a 30 minutes drop in the time to treatment produced substantively better outcomes. So the percentage of patients with a modified Rankin score of 0-1 discharge 0 to 1 as discharge was 38% the 0 to 60 minutes patient. إذا السكور تبع الموديفايد رانكينج سكور أو السكيل كان 0 to 1 عند الديسشارج عند خروج المريض لدى 38% من المرضى الذين تلقوا العلاج من 0 إلى 60 دقيقة. 33% in those treated after 91 to 120. إذا البرسنتج يتدنى. And 28% in those treated 121 to 180 minutes after symptoms onset. Okay, so let's go to the quiz. Okay, جاهزين لبعض الكويز لو سمحتم سريعا؟ كويز سريع لو سمحتم. Patient treated with intravenous tissue plasminogen activator اللي نعرف بالTPA within the first of their stroke onset has significantly better outcomes at hospital discharge compared with patients who were treated later, according to data of acute ischemic stroke patients. Then, patient treated with intravenous tissue plasminogen (TPA) within the first 30 minutes, 60 minutes, or 120 minutes. What do you think? إذا تشير البيانات هنا كما قلنا أن الذين تلقوا علاج الترومبوليز بالساعة الأولى في بداية السكتة الدماغية. What do you think? الساعة الأولى أو 30 minutes أو 120 minutes؟ نوران بيقول 30 minutes. Okay, so it's 60 minutes. Okay, في الساعة الأولى قلنا golden hour في الساعة الأولى. Okay, ما يعرف golden hour. Quiz 2, treatment with intravenous tissue plasminogen activator is a treatment with TPA in the first 60 minutes is associated with more frequent independent ambulation at discharge to home, freedom from disability or dependence at discharge compared with patient treated at 61 to 90, 61 to 120, 61 to 180, 120 to 180. إذا في الممارسة السريرية إذا قلنا تظهر دراسات أن العلاج بالتي بي اي مقارنة بالعلاج بوقت لاحق يرتبط بزيادة تحرك المريض بشكل مستقل عند خروجه من المستشفى أو خروجه إلى المنزل، وهنا للكل لديه حرية الحركة بدون إعاقة عند الخروج من المستشفى مقارنة بالمرضى الذين يتلقون العلاج في الفترة التي هي 61 to 90, 61 to 120, 61 to 180 or 120 to 180. What do you think? What do you think? Okay, so for sure it's 61 to 180. Patient treated with intravenous TPA in the first 60 minutes of their stroke onset was linked with what percent of relative increase in being non-disabled at hospital? It's 72%. Okay, let's skip the quizzes and talk about fitness training. Okay. Let's talk a little bit about stroke rehabilitation from basics to advances. اوكي سنتكلم عن الامور المتقدمه من البيزكس والامور المتقدمه في العلاج الستروك. So the fitness training تعرفون ما هو، إذن هي الأنشطة المنظمة ومخططة بشكل مناسب وتشمل حركات مستمرة ومتناسقة للعضلات وأكيد بهدف الحفاظ على اللياقة البدنية وزيادتها، وتستند إلى مبادئ الفيزيولوجية التي تزيد من القدرة على نقل الأكسجين واستخدامه أثناء النشاط البدني. Okay. What the advantages? It's easy administered and relative low cost, possibility of being delivered to group. إذن هي easy administration سهلة وممكن to deliver to a group لمجموعة وليس لشخص فقط. Clearly established evidence. So what are the evidence? For stroke patient with mild to moderate impairment. So stroke patient with mild to moderate impairment at both the acute and chronic stages in outcomes, such as maximal oxygen consumption, gait capacity, and speed. The limited scientific evidence to improve quality of life. Okay, we have limited scientific evidence about improving quality of life. Constraint-induced movement therapy. Okay. وهنا هو إذا أردتم نوع من التمرين يركز على تحسين وزيادة استخدام الطرف الأقل استخداما عند الأشخاص الذين يعانون من مشاكل في ستروك في أحد الأطراف. وهنا يتكون من 3 أركان أساسية، هي تقييد الطرف الغير مشلول، الطرف الجيد، تدريب مكثف وموجه نحو المهمة المطلوبة، والطلب من المريض تحريك بالقوة تحريك الطرف الجيد أو الطرف المشلول عفوا، وتربيط وتقييد الطرف الجيد. وأيضا هنا so here the activities is to be trained maybe those that are part of the patient's daily lives and be administered with their life context. What are the clearly established evidence? So it's for stroke patients at acute, subacute, and chronic stages, and outcome related to the quantity and the quality of the use of the paralytic upper limb in daily life, dexterity, and motor recovery. The limited scientific evidence for the lower limbs and outcomes related to strength. What are biofeedback? So here the advantages of the biofeedback. So the physiological information is continuously and simultaneously delivered in an objective manner and is specific to be trained to the trained movement, activity, or task. Clearly established evidence. So what are the clear evidence? It's for stroke patient at the acute, so at the acute and subacute and chronic stages, and also to improve activities performance or related to the lower limbs like stand-up gait and sit-to-stand. The limited scientific evidence or limited scientific evidence for sensory motor impairment activities related to the upper limb and spasticity that interfere with activity or personal care. Okay, what about the electrical stimulation? So the electrical stimulation, it refers to the stimulation of an intact lower motor neuron by an electrical current generated by an apparatus. So it can be used to activate paralyzed or paralytic muscles, aiming at generating muscle contractions or modulating neural activity, to regain voluntary contraction or to prevent abnormal muscular reactions. What are the advantages? So in precise sequences and magnitudes, electrical stimulation can be used to directly accomplish functional tasks. What are the clearly established evidence? So it's for patients at the subacute and chronic stages to improve muscular strength and activity performance. What are the limited scientific evidence is to prevent or treat swelling. So there is limited evidence to prevent or treat swelling of the extremities and to deal with spasticity that interfere with activity or personal care. Let's move to the progressive resistance training. So it refers to the use of progressive overload applied to a specific muscular group to stimulate further adaptation towards specific training goal. So the progressive training هو هنا نشير إلى استخدام بطريقة إلى استخدام زيادة تدريجية في الوزن على مجموعة من العضلات محددة لتحفيز وتكثيف إلى الماكسيموم نحو أهداف التدريب المحدد. So the advantages of progressive resistance training: low cost, easy to administer, and may be delivered in groups. Also, it can be used for muscles of different segments like upper limb, lower limb, and trunk, and also for the respiratory muscles. Clearly established evidence for the weak patient at the acute, subacute, and chronic stages. إذا ممكن أن نطبق هذه التقنية على البيشنت اللي هن في مرحلة acute, subacute, and chronic stages, without any adverse effects, even on spasticity, to improve strength, gait performance, quality of life, and oxygen consumption. What are the limited evidence? It's to improve mobility. We have limited evidence to improve mobility, sit to stand or stair climb, the performance of activities related to the upper limbs, and functional performance in general. Mirror therapy, okay, it focuses on moving the unimpaired limb while the patient watches its mirror reflection superimposed over the impaired limb that is unseen, thus creating a visual illusion of the movement capability of the impaired limb. إذا نركز هنا على تحريك الطرف السليم بينما يشاهد المريض انعكاس المرآة لهذا الطرف فوق الطرف المعوق الذي لا يراه، مما يخلق وهما بصريا يساعد الطرف المعوق على الحركة. Okay. What are the advantages? Low cost and it's easily performed. The patient may perform the intervention by themselves. Okay. Clearly established evidence for weak patient at the acute, subacute, and chronic stages to improve the following outcomes related to the upper limbs, like pain, okay, بيخفف الوجع, الألم, motor function, and the performance of functional activities. The limited evidence to improve range of motion, visual spatial neglect, and the performance of activity of daily living. Bobath concept, okay, it's defined by the International Bobath Instruction Training Association as a problem-solving approach for the assessment and treatment of individuals with disturbances of function, movement, and postural control due to a lesion of the central nervous system. So the aims are to identify and analyze problems within functional activities and participation in everyday life, as well as analyze movement component and underlying impairment. So it's based upon afferent information named facilitation to enable successful movement and task performance. What are the advantages of that concept? It's a global strategy with a holistic approach, but it requires expert training to be delivered. Is there any evidence? There is no evidence that the Bobat's concept is superior to other approach. Transcranial magnetic stimulation. So it's an intervention aiming at altering the stability of the motor cortex. So improvement in motor performance after stroke have been found after inhibiting the affected hemisphere. So as well as increasing the excitability of the affected hemisphere. إذن التحفيز المغناطيسي transcranial magnetic stimulation هو التدخل يهدف إلى تغيير قابلية التحفيز القشرة الحركية ثم العثور على تحسنات في الأداء الحركي بعد السكتة الدماغية. وكذلك أيضا زيادة قابلية التحفيز للنصف المتأثر في الجلد. إذن, what are the advantages? It can be implemented for stroke patients with severe motor impairment. The limited evidence to improve motor recovery at the acute and chronic stages. At the moment, no adverse effects have been reported. Task-specific training. It consists of repetitive training of movement directly related to functional activities. Okay. إذا التدريب محدد يتكون من تدريب متكرر للحركات المرتبطة مباشرة بالأنشطة الوظيفية. What are the advantages? So it can be performed as circuit training and delivered to groups. The intensity of training can be adjusted and progressed to fit the individual's needs. Clearly established evidence. So for stroke patients at the subacute and chronic stages to improve balance, sit to stand, reaching, manipulation, and walking performance. Then good evidence. Mental practice. It's a cognitive strategy in which a brain area related to specific motor action is triggered repeatedly through the activation of the imagination with the goal of improving the patient's performance. إذا التمرين العقلي إذا أردنا أو الذهني استراتيجية إدراكية، أنه استراتيجية إدراكية يتم فيها تنشيط منطقة في الدماغ مرتبطة بإجراء حركة محددة بشكل متكرر من خلال تنشيط الخيال وبهدف تحسين أداء المرض. What are the advantages? For many individuals with nervous system damage, the execution of certain movements is very difficult and sometimes even impossible, which hampers their active participation in the rehabilitation process. In this sense, mental practice allows the realization of all movements. Is there any limited scientific evidence? Okay, we have limited scientific evidence of the benefits of mental practice in addition to other rehabilitation strategies for measures of upper limb function. No adverse effects with stroke patient at the acute, subacute, and chronic stages were observed. Finally, uh, we're going to talk here about the virtual reality therapy أو العلاج في الواقع الافتراضي. It refers here to use of interactive stimulation generated from images, such as computer processes, to provide the user the opportunity to interact with environments that simulate real objects and events. So through a virtual environment rich in detail, virtual reality simulates functional tasks that are intensively practiced. هنا نشير إلى استخدام ما يعرف بالمحاكاة التفاعلية مستندة إلى الصور مثل معالجات الكمبيوتر وكل هذا لتوفير فرصة للمستخدمين للتفاعل مع بيئات تحاكي الأشياء والأحداث الحقيقية. من خلال بيئة افتراضية غنية بالتفاصيل يقوم الواقع الافتراضي بمحاكاة المهام الوظيفية أو تفعيل المهام الوظيفية التي يتم ممارستها بشكل مكثف. What are the advantages? Virtual reality programs simulate real-life functional activities in an interesting and challenging manner and encourage the practice of a higher number of repetitions. Moreover, the difficulty of the tasks can be graded on, and the physiotherapists can simulate tasks that could not be done within clinical settings, such as crossing a street, for example. Is there any limited scientific evidence? So the limited scientific evidence of the benefits of virtual reality compared with the same doses of conventional rehabilitation strategies for measures of upper limb function and daily life activities. So there is limited evidence of the effectiveness of virtual reality in measures of grip, strength, and gait speed. Okay. Let's move here to talk a little bit about the technology in rehab. Okay. So the technology in rehab provide real-time biofeedback like feel, see, and hear. So objective measures like monitor progress, tracking outcomes, evidence for third-party payers, clear to patients. Also relevant to society, motivating, engaging, and stimulating. Also we have the marketing tool like screening and research, real-life simulation in clinic, and errorless learning. إذا التكنولوجيا in rehab توفر ردود فعل حية للمستخدم كالشعور والرؤية والسمع، وأيضا هنالك قياسات للأهداف ورصد للتقدم، وهنا نتبع النتائج ونثبت للجهات الأخرى التي مثل الانشورنس أو غيرها أن المريض يتحسن، وأيضا الهدف واضح يكون للمريض، وهي ذات صلة بالمجتمع وتعتمد على التحفيز وإشراك المريض ومحاكاة الحياة الواقعية أيضا، وهذا يكون تعلم خالي أو إعادة تأهيل خالية من الأخطاء. Okay. There is three crucial elements for the acquisition of motor progress through rehab, like adequate feedback, variability of practice, and design of learning situation. إذا هناك ثلاثة عناصر حاسمة لاكتساب برامج حركية من خلال التأهيل، وهي توفير ردود فعل كافية، تنوع في الممارسة، وتصميم في حالة التعلم. تمام؟ Okay, let's start with the Biodex balance system. Okay. It's a force platform for testing and training of static and dynamic standing balance. إذن هي منصة قوة لاختبار وتدريب التوازن الثابت والديناميكي للوقوف. Capabilities for risk screening and training, postural stability, clinical test of sensory integration of balance, compare score of age, the dependent norms, charts progressive over time, determine which of three balance system PT is relying on, and also there is a screen concussion. إذا فحص هنا يتم فحص وتدريب مخاطر السقوط وتجنب مخاطر السقوط واستقرار الوضعية اختبار السريري هنا لتكامل الحواس أو الكلينيكي لتكامل الحواس في التوازن، مقارنة النتائج مع المعايير العمرية الاعتيادية، وتتبع التقدم مع مرور الوقت. NeuroMove, what is the NeuroMove? What is used for stroke rehab by muscle re-education, relaxation of muscle spasm like spasticity, prevention of retardation of disuse atrophy, increased local blood circulation, maintaining or increasing range of motion. إذا بيستعمل هنا NeuroMove لتأهيل السكتة الدماغية عن طريق إعادة تأهيل العضلات، تخفيف تشنجات العضلات، وقاية من تأخر أمور العضلات الناتجة مع عدم استخدامها، زيادة الدورة الدموية المحلية، والحفاظ على حركة المفاصل وزيادتها. How it works: detects attempts below where trace movement are visible, distinguishes between regular muscle activity and muscle tone and real attempts. إذا يكشف هنا عن المحاولات التي تحدث حيث تكون حركات ضئيلة وغير مرئية. When a real attempt is detected, the unit rewards the patient with muscle contraction, visual and sensory feedback, serves as an important element in relearning the movement. And it's very motivating. So they see they could make a difference where previously they had no indication of their attempts. إذن هنا عند اكتشاف محاولة حقيقية للحركة يكافئ هذا الجهاز المريض بانقباض العضلات، وتعتبر التغذية البصرية والحسية هنا ردود الفعل الهامة في إعادة تعلم الحركة. وتعتبر هذه العملية محفزة جدا وللغاية للمريض، حيث يمكنه أن يرى أن بإمكانه إحداث الفرق، حيث كان في السابق أن لا يكتشف محاولته بأي وسيلة أو لا يلاحظ محاولته لإيجاد حركة. Okay. RNO boom spring power, suitable for individuals who have suffered strokes, traumatic brain injuries, or neurological disorder resulting in hand and arm impairment. The RNO هو مناسب للأفراد الذين تعرضوا لسكتات دماغية أو إصابات في الدماغ ناجمة عن صدمات أو اضطرابات عصبية، والتي قد تؤدي إلى إعاقات في اليد والذراع. هنا أيضا how it works: it's adjustable arm support with a highly sensitive hand grip and video game like exercises to stimulate arm movement used in specific real-life tasks. Also, it's an exercises are carried out in the virtual environment on a computer screen, providing goal-oriented tasks and giving immediate visual feedback. Use residual neuromuscular control to perform the exercises and gradually build strength in arm. Also, built-in sensor and software record arm movement at each joint, so therapists can track improvement, determine the appropriate difficulty level for patient, and customize training program as patients progress. إذن يتم هنا محاولة مساعدة الذراع ودعم الذراع القابل للتعديل مع قبضة يد حساسة جدا، وأيضا تمارين تشبه ألعاب الفيديو لمحاكاة حركة الذراع المستخدمة في مهام الحياة الطبيعية. وهنا ينفذ التمارين في بيئة افتراضية على شاشة كمبيوتر، مما يوفر مهام موجهة نحو الهدف وتعطي ردود فعل بصرية فورية، حيث يستخدم التحكم العضلي العصبي المتبقي لأداء التمارين وبناء القوة تدريجيا في الذراع. وهنا يسجل حركات الذراع في كل مفصل باستخدام الأجهزة الاستشعارية والمدمجة والمبرمجة، بحيث يمكن للمعالج تتبع تحسن المريض وتقدمه وتحديد مستوى الصعوبة المناسب للمريض، وأيضا تخصيص برنامج تدريب مخصص مع تقدم المريض. Locomat, it's robotic gait or orthosis, longer and more intensive training session compared to manual treadmill training, real-time feedback for a higher motivation and compliance. So gait asymmetry may be associated with many potential negative issues. Example, challenges to balance control, increased energy expenditure, increased risk of musculoskeletal injury to the to non-paratic lower limb or lower extremity, and decreased overall activity levels. So the Locomat هو جهاز روبوتي للمشي، وهي هنا يعتمد على جلسات تدريب أطول وأكثر كثافة مقارنة بجهاز المشي اليدوي والمعروف يعني. وقد يكون هنا التشوه في المشي أو ضعف في المشي مرتبطا بالعديد من المشكلات السلبية المحتملة، بحيث أن هذه التحديات في التحكم في التوازن وزيادة النفقة الحرارية إذا أردنا، وزيادة مخاطر الإصابة العضلية الهلكيلية في الطرف السفلي غير المشلول، وانخفاض مستويات في النشاط العام. Evidence assumed reduced spasticity, improved walking ability, increased alertness, strengthened leg muscles, improved stamina, and increased motivation. There is evidence إذن يفترض أن يقلل من التشنج، يحسن من قدرة المشي، زيادة الوعي واليقظة، تقوية عضلات الساق، تحسين القدرة على التحمل، وزيادة الدافعية والنشاط. Severely impaired ambulating stroke patient benefits from the task-oriented and intensive training. By ambulating stroke patients show improvement with the Locomate system as well, but require a challenging and variable training program via therapists. Locomotor improvements might depend on an early training onset as well as a high number of repetitions, which can be applied with the Locomate system. إذن هنا يظهر مرضى السكتة الدماغية القادرين على المشي تحسنا باستخدام هذا النظام، ولكن يتطلبون أيضا برنامج تدريب وتحدي عن طريق معالج. إذن دور المعالج مهم في هذه المرحلة. وهنا يجب الإشارة أن تحسنات المشي قد تعتمد على بدء التدريب المبكر وعدد مرات التكرار، ويتم تطبيقها باستخدام هذا النظام. Okay, MIOMO, it's a brain injury rehabilitation by muscle re-education and maintain or increase range of motion. إذا هو يستعمل هذا النظام لتأهيل الإصابة الدماغية عن طريق إعادة تأهيل العضلات والحفاظ على نطاق الحركة وزيادتها. How does it work? The arm brace has EMG sensor that sit on the skin's surface and detect even a very faint muscle signal. So a person with weak or partially paralyzed arm tries to move their arms and a muscle signal fires. The robotic in the Empower engaged to assist in completing the desired movement. So in helping achieve desired movement, the device can be worn as a functional aid used during exercise to maintain gain, or applied as a rehabilitation device that reteaches arm movement to the brain. هي نوع من الجهاز كما قلنا يوضع على الذراع ويحتوي على أجهزة استشعار، والتي تأتي لتلمس سطح الجلد وتكشف حتى أي إشارة عضلية ضعيفة جدا. إذا هنا عندما يحاول الشخص الذي يعاني من ضعف في الذراع أو شلل جزئي، عندما يحاول تحريك ذراعه يتم تشغيل الجهاز الروبوتي ويتم بشكل تلقائي مساعدة المريض في إكمال الحركة المطلوبة. إذا يعمل ستيميليشن لمساعدة في إكمال الحركة المطلوبة. إذا من خلال هذه المساعدة في تحقيق هذه الحركات المرغوبة، هنا يمكن ابتداء هذا الجهاز كمساعد وظيفي أو استخدامه أثناء ممارسة التمارين للحفاظ على التحسينات المحققة، أو أيضا استخدامه كجهاز لإعادة التأهيل ولإعادة تعليم الحركة أو حركة الذراع للدماغ. Okay. A three-step supported ambulation. As description, it's a body weight supported harness for gait uses an overhead track and harness. Purpose, the therapist and the PT safety and independence, decreases fear of falling, requires less staff for balance activities and more assisting, less supporting. إذن الفري ستيب سبورتد امبوليشن هو حزام يدعم وزن الجسم للمشي ويستخدم أيضا طريقة يعني يعلق في السقف لتخفيف وزن المريض. الغرض هو ضمان سلامة المعالج والمريض واستقلاليته، وأيضا تقليل خوف لدى المريض من السقوط، ويتطلب عدد أقل من الموظفين عندما نساعد المريض على السير، وأيضا يوفر دعما أقل ومساعدة أكثر. Tibian leg orthosis, it's a robotic aid that aids the knee in flexion and extension, activated by foot sensor, follows parameters set by the PT. Worn during therapy sessions for strengthening and movement training. إذا هو مساعد روبوتي على ثني واستقامة الركبة ويتم تفعيله بوسط مستشعر القدم، ويتبع المعايير المحددة من قبل المعالج الفيزيائي، ويتم ابتدائه خلال جلسات العلاج لتقوية العضلات وإعادة تدريب الحركة. What are the benefits? So more sit-to-stand exercises. We have more sit-to-stand exercises, more overground steps per session, more repetition of stair climbing, increased potential for neuroplasticity. As per the evidence, improve gait speed, endurance, and balance. إذن فوائده المزيد من تمارين الجلوس والوقوف، المزيد من الخطوات خارج الأرض في كل جلسة، والمزيد من تكرار تسلق السلالم، وزيادة الإمكانات لتحفيز العصب، وأيضا يحسن في سرعة المشي والقدرة على التحمل والتوازن. Finally, what we call it Karen, it's a computer assisted rehabilitation environment. Okay, so the Karen, it's a 21-foot dome, helps researchers analyze how patients react to different walking speeds, inclines, and environment. إذا هو نوع من قبة بارتفاع 21 قدما، يساعد هذا الديفايس الباحثين في تحليل كيفية تفاعل المرضى مع سرعات المشي المختلفة ومع المنحدرات والبيئات المختلفة. Walking down a busy street, see other pedestrians around, so see the buildings, hear and see traffic. I walk in the woods also, see the trees, hear the wind and the birds, feel the trail twist and turn under feet. إذا المشي في شارع مزدحم، مشاهدة المرة الآخرين من حول المريض، النظر إلى المباني، الاستماع إلى الحركة والنظر إليها. هنا نسأل المريض هل تمشي في الغابة، يشاهد الأشجار، يستمع إلى الرياح، وأيضا يشعر بتحرك المسار تحت قدميه. كل هذا ممكن أن يحصل من خلال هذا الجهاز. Computer linked to sensor on the body, move a treadmill to match the ground. You'll be walking over and adjust video images all around to what patient would like to see and hear when walking. إذا يتصل هنا الكمبيوتر بمجسات على الجسم لتحريك جهاز المشي لمطابقة سطح الأرض الذي يتم المشي عليه، وضبط الصور المرئية في جميع الاتجاهات بما يتوافق مع ما يرغب المريض في رؤيته وسماعه أثناء المشي. وأيضا ممكن can be used with wheelchair، ممكن استخدامه في الكرسي المتحرك. Okay, this is the device Karen, which is very important and interesting. This is the references. Okay, thank you so much. شكرا. هل هناك أسئلة؟ Any questions, please? Any question? Okay. بريك، لكن بريك بسيط وتعودون مع أحد الزملاء لإكمال هذا النهار. شكرا، يعطيكم العافية. إذا بريك حتى الساعة الواحدة. بريك حتى الساعة الواحدة، بريك الغداء. lunch break till 1. Thank you.
Hello. Okay. السلام عليكم and welcome to the last part of the webinar. بنكون مع القسم الأخير من الويبر إن شاء الله, and we will be talking about the quality of life for patient and family in the chronic disease. فإذا هنتكلم إنه كيف ممكن نحن إيش الأشياء اللي ممكن تحسن صحة الفرد والعائلة قبل ما نوصل للديزيز. يعني نحن الديزيز في عدة عوامل أو we have different factors that might lead for diseases. يعني في عنا العامل الوراثي family اللي تكلمنا عنه يعني يعني الهيريديتي يعني الاشياء العائلي والوراثيه. بس كمان نحن we have or we are playing a very important role on preventing and managing many diseases. يعني أنا بعرف I have family history of diabetes, I have family history of hypertension, of cancer, of I don't know. طيب what shall I do؟ يعني أنا بهالحالة أنا what will be my role؟ How I could prevent it؟ هل يا ترى chronic disease do you think it's unpredictable؟ At some point I would say إنه يمكن لا, لأنه أنا بعرف مثلا I have history family history of diabetes type 1 for example, يعني by default I'm going to get it. Or but however the complication is predictable, yes. I could work on the complication for sure, yes. Okay, for sure, yes. We will be talking about the quality of life. رح نركز على الأشياء التي يعني ما رح أركز على موضوع الديزيز بما إيش هي الأشياء that we could do it on a daily basis as patient, as family, as member in order to avoid the complication. بما انه مثل ما حكينا الديزيز زي ما بيقولوا واقع واقع ما في انا I cannot avoid. يعني شو ما اعمل ممكن انا الكانسر مثلا I cannot predictable, it's unpredictable. diabetes نفس الشيء. then what shall I do as a patient and family as well عشان to work on avoiding the complication. فاذا رح نحكي education concerning prevailing health problem and the method of preventing and controlling them. Promotion of food supply. هل يا ترى الفود supply يلعب دور بالchronic disease؟ We will see when nutrition or that the food that we are you know take it on a daily basis, or the food or that some of the company they flood on the يعني سوبر ماركت. يعني هالمواد اللي بتستعمل هل يا ترى تلعب دور في الكانسر فور اكزامبل؟ maternal and child health care. What is the role including family planning. الاميونيزيشن هل يا ترى الاميونيزيشن يلعب دور في ايضا preventing and control of local diseases. treatment of common disease and injury and training of health guide. فعشان كلياتها مواضيع اللي حنشوف ايش الريليشن بين الكرونيك ديز امراض الوراثيه كيف ممكن امنع الكومبليكيشن. اجين يعني نحن بدي اشتغل على موضوع الكومبليكيشن اكثر ما يكون يعني على موضوع يعني رح بلش فين one by one. education concerning prevailing health problem. يعني for example I have a family history of diabetes. For sure I need to start earlier, especially it's diabetes type 1 or type 2, to take all the prevention measures already بالقسم الأول بالسيمبوزيوم تكلمنا عنها من خلال الهيلثي فود ومن خلال يعني الاكسرسايزنج وافويدنج الكالوريز وافويدنج الكربوهيدرات والى اخره. Promotion of food supply and proper nutrition. Do you think there is any relation between the food and some of the disease, for example, or chronic disease. What do you think? هل يا ترى في تحس إنه في علاقة بين نوعية الأكل والمأكولات اللي نأكلها والأمراض الوراثية، وإيش هي العلاقة؟ Any idea? As in what kind of relation existing between the food supply or nutrition supply and the, for example, some of the disease? Give me example, and do you think what types of relation existing? For example, let me give you example. إذا بناخذ موضوع الكانسر، أوكي، في كتير دراسات أجرت إنه الأطعمة يعني المعدة للاستعمال for long time، يعني فور اكزامبل بنشوف الأطعمة المعلبة اللي داخلها مواد كيميائية للحفظ. هذا من أثبتت الدراسات أنه هي من الأسباب التي يمكن أن تلعب دور في موضوع الكانسر. وضحت؟ فإذا نحن الفود is playing a big role. أنا بعرف أنه فور اكزامبل الأشياء المعلبات والأشياء اللي داخلها مواد كيماوية هي كمان ممكن تكون تؤثر بشكل غير مباشر ممكن أو مباشر حتى بموضوع الكانسر. فإذا هيدي قصة الفود سبلاي وإلى آخره. طيب فإذا نحن وقت بنحكي عن الفود سبلاي maternal and child، شو الفود سبلاي اللي ينصح فيه عشان امنع انا بعض الديزيز؟ يعني سواء you have any type of chronic disease، ممكن ننصح مثلا باكل كثير الاشياء الخضروات، البروكولي والافوكادو this is all a food that containing a high protein plus fibers and playing a very important role on your health. And this is, we have a lot of food that we could use it on a daily basis, at least containing a high fiber and high protein, and shouldn't take too much calories and carbohydrates, especially for those who have a high risk of a family history like diabetes and hypertension. Maternal and child care. What do you mean by a family planning? And do you think there is what kind of relations existing between the family planning and some of the diseases? Give me example. Like what? How we could avoid through the good family planning a chronic diseases? Like what? ممكن تعطوني مثل؟ Any idea? For example, a couple is going to get married, and one of them they have history of he is already a patient with diabetes type 1. For sure, in the family planning, they need to be aware that the baby, big possibility or big probability, is going to be a diabetes type 1. Okay. For example, another family planning that or another components that needs to be taken in consideration. Another example, the family planning. For example, you have a history in the family of congenital abnormalities in the family. One of the child or one of the kids, or he has a difficulty during delivery, or let's say he has a abnormalities or congenital malformation. This is another one to be taken in consideration while planning for a a family plan. Immunization against a major infection disease, like what? Give me example. Immunization against major infection diseases, like what? شو هن الميجر infection diseases؟ شو بنحن بناخذ immunization؟ Give me example of immunization. Like hepatitis B, for example. poliomyelitis. This is all a immunization. Prevention of endemic disease, the common disease with local. Right. Let's move to the in order to have to promote the health والprevention of the chronic diseases فإذا the prevention of the chronic diseases, it's a part of the health promotion and فإذا نسميه health promotion and diseases prevention. يعني أنا if I promote the health of a human being, of a population, for sure by default I'm going to decrease the diseases. يعني how to promote the health of our population in order to prevent the chronic disease. Example, physical activities. This is highly required and this is very important to prevent the diseases. For this reason, nowadays you could see that a lot of companies, a lot of uh, organizations are pushing their employees to do activities on a daily basis. For example, if you now in many organizations, they open a gym for their employee. Okay, you have the right to go, for example, half an hour, 1 hour on a daily basis just to practice your activity. For example, if you have a history of diabetes, hypertension, obesity, it's very good just to go at least 2 or 3 days per week, 40 minutes per day, and to do some of the aerobic, exercising like walking outside. Or this is very important as a physical activities. It's very important, and it's required to everyone, especially for those who have a history of diabetes, hypertension, any type of diseases, because the physical activities it's the major or the main components of the health promotion. Right. Healthy eating, already we talk about it. We need to avoid especially the saturated fat, especially the eating from outside, for example, in the fast food or food that already prepared outside, oily food that we don't know who prepared, how it was prepared, that it might take 1 minute for preparation. We need to focus on the food, healthy food that containing a high protein, low carbs, and low sugar, low cholesterol, and low. This is, we need to focus on this. And now you will see how you will see that if you will go to the supermarket, for example, now, or you will go to any restaurant here in Riyadh. Okay, what did you notice over the last years? Before, for example, you can go to any restaurants. You might order, for example, any types of food. Maybe it's containing 3,000 calories, but you are not aware. Okay, you are not aware. For example, I will give you myself. I was going to the restaurant. I was ordering a chicken strips. For me, it's a small. It's not containing too much calories, and compared to, for example, to the high meals. Now this is oily, and this is it's containing. I don't know. Now, in order to promote the health of population, you will see any restaurant you will go, the meals calories, it's written. Now, if you are going to order any types of food, you will see that the number of calories already written on the plate. And it helps a lot because, if, for example, I am going to work on my diet to decrease my diet or to decrease my weight, and I went to a restaurant, and I am between two meals. I will take meals number one containing 3,000 calories and meals number two containing 1,500. Now by default, now I will go to 1,500. For sure, 3,000 is going to be more tasty, especially those who are in love with the fatty food. But once it comes to health promotion, we need to focus on the calories and the quality and what are the contents or what's containing this. Stop smoking. And this is another big dilemma, I would say, or big problem that facing everyone. Because always, many people or many population, they stop or they have the smoking cessation, but at the same time, they are using another ways of smoking, another more dangerous ways for smoking. And they thought that there is no healthy issues with this, vibes and whatever or shisha, but they are more dangerous more than the cigarettes. At least with the cigarettes, maybe you could control yourself, but with the vibes and shisha, it's out of control. And when you fall down, you will know the how much it's dangerous. Okay, community development. What do I mean by community development? An example of community development. What do you mean by community development? How the development of the community or community it's playing an important role in the health promotion, disease prevention, and the chronic disease prevention. By what? Give me example. Community prevention by proper education, education measures, education prevention. For example, now if you go to any shopping malls in different part of the kingdom, you will see, for example, they made an awareness day on, for example, healthy food, awareness day on the cancer, awareness day on fasting during Ramadan. We have this is part of we call it a community development that you will go to the community, especially where it's very crowded. You will find a lot of people who don't have access to the education center or to the organization. They will get a great opportunity for learning and development by explaining all the education measures, prevention, and sometimes give them materials in order to avoid or to work on the prevention of some of the disease and complication, that might happen, especially during some occasion. For example, now during Ramadan only. Healthy schools. What kind of relation between the schools or healthy schools and the health promotion and disease prevention? As in schools, for example, now controlling the quality of food given to our kids. For example, as you know, kids, they have diseases as well. Diabetes type 1, it will start with the kids. It's a young age. Now, if there is no control in the school for such type of patient, it will be a disaster. As an health school, very important by providing or by putting the sports exercise or 1 hour or 2 hours per day to do physical activities to be part of the curriculum. And I'm sure now all the schools are putting the physical activities as main part of their curriculum in order to push our kids to doing more exercise and the ultimate goal is to work on the prevention of some disease or try to control disease as much as we can. And health trainer now, for example, let me give you example, and this is it make us very happy now. A health trainer to have a gym now. Gym it's open for everyone. Female they can go to the gym now. There is a special gym, for example, for females. There is a lot of academies nowadays everywhere, different parts of kingdom, for example, where you could put your kids in a formal professional academic to train your kids and to be, for example, uh, and to be, for example, in the future, for example, a professional, to be in the future a professional, for example, player. Okay. بنشوف احنا for example we have different academies, for example like what different gym أكاديمية لكرة القدم وإلى آخره. فإذا هيدي كلياتها do you like to add anything for the health promotion غير هذه النقاط اللي قلناها؟ And this is all for the health promotion. طيب. How we could measure that our people or our population are at high risk for chronic disease. يعني كيف أنا بعرف you have a number of population. أنا عندي population معين بcommunity معين. كيف بدي أعرف أنا إنه my population are at high risk of chronic disease? How I could measure it. إذا بتقولي لي أنا كيف ممكن أعرف إنه مثلا قديش how I مثلا بتقولوا لي هل تعتقدون إنه مثلا the Saudi population are at high risk of chronic disease? You might say yes or no. طيب I will tell you if you will tell me yes or no. بتكون give me the evidence how you could measure it. مثلا دايما بدي يكون في عندي measurement عشان أعرف if my risk are at high risk of chronic disease. For example, like what? Gathering information from أول شيء بدي أعرف معلومات عن population. For example, from different data sources like birth and death certificate. إيش علاقة البيرث والdeath certificate بالchronic disease أو بالديزيز؟ كيف أنا بعرف من الdeath أو birth certificate بالchronic disease؟ إيش العلاقة بين الاثنين؟ كيف في أعرف يا أخوان؟ يعني أنا for example بعطيكم small example تنعرف كيف تعمل measurement. For example نحن in a place in one of the Arab country ببلد معين من الدول العربية لاحظوا أنه بمنطقة معينة في نسبة أعداد الأشخاص المتوفين بكانسر الرئة سجلت خلال سنة يا سنتين ارتفاع ملحوظ بعدد الحالات التي سجلت في الكانسر بالرئتين. تبين مع الوقت بواسطة الديث سيرتيفيكيت إنه اللي توفوا كلياتهم هن كانوا يعملون بمصنع للمواد الكيماوية، ومع الوقت سجل إنه صار في عدد لا بأس به منهم صار في عندهم حالات كانسر الرئة. فأصلا هيدي من الأشياء خليني قيس قديش البوبوليشن عندي معرضة للديزيزز وباخد الأكشن على أساس. أوكي. فإذا البيرث سيرتيفيكيت كمان إذا بمنطقة معينة بمكان معين سجلت نسبة وفيات أثناء الولادة لعدد لا بأس به بمنطقة معينة. طيب ليش؟ هل يا ترى إيش مشكل؟ هل عندي مشكل أنا بتثقيف الأمهات والعائلات فور اكزامبل؟ هل عندي مشكل بالولادة بحد ذاتها وايل ديليفري؟ هل عندي مشكل بالسيستم؟ فإذا هون while getting a survey about it وتبعرف أنا data what are the cause of birth and death certificate reasons. I will work on the reasons or on the causes to promote my community and to help on the prevention of the disease. بدي أعرف يعني مثل ما حكيت سجلت نسبة حالات لا بأس به من الكانسر، عندي عدد كبير لا بأس به من المرضى لديهم يعني أمراض السكر. طيب ليش كومبير مثلا إذا بشوف أنا عندي نسبة من سنة 2000 لل 2010 كان عندي نسبة حالات السكر سجلت فور اكزامبل 100,000، بال 2010 2020 صار عندي 200,000. طيب ايش السبب؟ أنا through the data collecting and gathering data I will have idea about what's going on. فإذا data very important, playing a vital role on the promotion and prevention of the chronic diseases. Okay, in the prevention and controlling of the chronic diseases لأنه data will give information about the cause, about the reason, and it will be a great resource for me in order to plan for the future about the action plan. كمان measuring social and environmental factors that influence health, such a number of fast food restaurant in low income neighbors. مثلا بعرف أنا بالمناطق قديش عندي نسبة المطاعم التي تقدم وجبات سريعة، هل يا ترى عم بتزيد عم تنقص وبربطها ببعضها. كمان measuring يعني measuring the number of people who get healthcare preventive measures من خلال مثلا الاسبرين يوز، بلاد بريشر، كوليسترول كنترول، سموكينج سيسيشن، دايابيتس كنترول، قديش عدد الاشخاص عم يعملوا افحاص سكر، عم يعملوا مخزون السكر الاي 1 سي، قديش نسبة هيدي كلياتها. فاذا نحن الداتا بتعطيني فكرة عن المستقبل. اذا انا بين عندي انه انا نسبة الوزن الزائد عند البوبوليشن هي 80% كاتاستروفي. اذا بين عندي انا انه عندي انا 30 40% من البوبوليشن they are diabetes patient it's a catastrophe. إذا عندي نسبة الضغط والسكر هيدي كلياتها الميجرمنت تعطيني. وقتها بعمل early measurement يا إخوان في اخذ الاكشن بلان. يعني انا بعمل ميجرمنت وباخذ بلان اكشن بلان منشان امنع هذا الموضوع بالفيوتشر، ما خلي هذا الموضوع. يعني بشتغل على الاسباب عشان خفف. اوكي. يعني نحن وقت لاحظنا انه عدد الوزن الزائد كثير كبير من المجتمع اشتغلنا بالمطاعم على موضوع الكالوريز. هلا ما فينا نجبر الناس ايش تشتري، بس انا على القليل بعطيكم فكره انه اذا اخذت هيدا الميلز هي 3000 كالوريز، اخذت هيدا الميلز 1500 and هيدي الضرر 1500 كالوري it's going to build a fat and it's going to close your arterial and it's going to affect your vascular and يعني عرفتوا كيف هون بربطها ببعضها and it makes sense وكثير خففت. احنا بتشوفوا كثير نحن نسبة السكر والضغط والوفيات والى اخره قلت عن مش مثل ما كانت بالاول. ليش؟ لانه درجة الوعي من قبل الجميع تحسنت بشكل ممتاز. improving environment to make it easier for people to make healthy choices مثل ما حكينا يعني من خلال السكول، من خلال child care programs، من خلال work site، كلياتها بتأثر بموضوع الهيلثي تشويس. health care system intervention ايش هو الموضوع التي هلا فتنا على موضوع المنشأة الصحية. ايش هو الدور التي تلعبه المستشفى بموضوع الهيلث بروموشن والديزيز بريفنشن. مثلا what are the role of the healthcare organization بموضوع الهيلث بروموشن والديزيز بريفنشن. What do you think? موضوع الهيلث كير سيستم انترفنشن. For example, improving access to healthcare for population with little or no access. بتعرف مثلا انه لا نحن شوفوا نحن وقت عملنا تيستيشن اتس everywhere، يعني نحن الحمد لله هنا بالمملكه السيستم از اوبن فور everyone، اصلا ممنوع حدا يشتغل باي منشاه الا ما يكون عنده الانشورنس والاكسس على الهيلث كير. فاذا هيدي يعني ما في نعطي اكزامبل كهنا، بس انه وقت انا بعطي اكسس مش بس اكسس علشان انه الانسان يمرض يروح، لا اكسس. فور اكزامبل نحن بنعرف في كثير من المستشفيات بتقول لك اليوم نحن عملنا اليوم التوعوي للوقايه من امراض الصدر، ويوم كشف مبكر عن امراض الكولون او الصدر، يوم مجاني فور اكزامبل. اوكي، يوم مجاني. فاذا هيدي كلياتها this is يعني الانترفنشن من قبل الهيلث كير سيستم to improve access to health care for population with little or no access. الكلام عن providing health insurance. أنا this is again نحن for us يعني الحمد لله إنه نحن كلنا عنا health access هنا ككينجدوم، سواء مواطنين أو سواء مقيمين. increase use of health information. كيف يعني increase use of health information؟ اوكي، كيف ممكن هذا الانكريز يوز اوف هيلث انفورميشن تكنولوجي and tools like ايه؟ for example like what؟ give me example. كيف شو هو الانكريز يوز اوف هيلث انفورميشن تكنولوجي بتلعب بهذا الموضوع؟ يعني نحن بنشوف في كثير كمان من الهيلث كير سيستم والمؤسسات والمنشآت بيعملوا مثلا ويبينار اوبن فور ايفري ون، على بيتكلم على موضوع فور اكزامبل الوقاية من أمراض السكر، الوقاية من الضغط، الوقاية من الكوليسترول، أهمية الفود، أهمية ما إلى آخره. يعني هنا كمان احنا فينا نستعمل هيلث تكنولوجي عشان تو بروموت الهيلث اوف population، وحكينا عنها يعني many example measuring and reporting on health system change. فإذا improving access to cancer screening for people with little or no health. يعني وقت بنعمل نحن هيدي يعني صراحة بنشوفها كثير حتى بالمولز، وقت بنروحها هيك بنشوف انه في كثير من المنشآت او الشركات او المستشفيات بيعملوا توعوي، يوم توعوي والى اخره بامراض الكانسر وامراض الدم والى اخره. Do you think it's very important to focus on the family history؟ نحن كثير مهمة وقت نحكي على موضوع الكرونيك ديزيز، الأمراض الوثائقية، أهم عامل وأهم رابط نركز عليه ونشتغل عليه. صحيح we cannot change it، يعني العامل الوراثي أو الهيلث history it's out of control، نحن ما بنقدر نغير فيه شيء. أوكي، بس نحن فينا نشتغل على complication. بس نحن مهم كتير to be aware do not neglect the family history. أنا ما في الفاميلي هيستوري يعني الموضوع وكأنه غير معني بالموضوع، لا. each one of us, each single person including us here in this webinar, we have a family history. We need to work on the family history. اوكي، بدي اشتغل عليها، ما بقدر غيرها، بقدر امنع الكومبليكيشن. and I'm going to give you few example of some of the family history. هعطيكم بعض example عن family history and to see what will be the best preventive measures مشان امنعها عندي بيها. كيف بعرف انا الفاميلي هيستوري؟ فاذا how I will know my family history؟ كيف انا بعرف الفاميلي هيستوري؟ فاذا كيف انا بعرف عن الفاميلي هيستوري؟ through what؟ by asking them. Thank you Sundus, this is a very simple asking. at some point يعني ما بحياتنا بنعتمد على الاسكينج بس، يعني we need to look after by looking after the death certificate. مثلا أنا بعرف بالعائلة عندي في نسبة for example 2 or 3 babies pass away. why؟ اوكي بنقول اوكي صار الموضوع والى اخره، بس why؟ always we need to ask. بعرف انه my mother she had a breast cancer, she is doing fine, thanks God. But if your mother she has a breast cancer, there is possibility, yes. There is no possibility, yes. But you can't say I'm doing sport, I'm doing exercising. My mother, she was a heavy smoker. For this reason, she got the cancer. For me, no. There is family history. Because your mother, even if you are healthy 100%, if you are doing all exercising, healthy food, your excellent lifestyle, but still you might get cancer because you have a family history. You might get it and you might not get. يعني ما في شيء بيقول انه 100% رح تاخديها، وما حنشوف. نحن بنشوف كثير من عيال they have a lot of family cancer وهن يعني ما في، ولا عكس الصحيح. فاذا collecting information about your parents, about your sisters, about your brothers, about your half sisters, half brother, children, grandparents, your uncles, your nieces, and your nephew. This is all it will give you. يعني مش بس الاقتباء المباشر، في الاقتباء البعاد شوي، أو including information on the major medical conditions. يعني ما بدي أقول أنا history of hair loss for example، لا ما مش هذا الموضوع. major medical conditions: hypertension, diabetes, cancer, cardiac arrest, cardiac diseases. This is cause of death, age of disease diagnosed, age of death, الباك يعني هيدي كلياتها we need to يعني ممكن نحن and nowadays we have a lot of family they have my family has portrait. يعني بتشوفوا انه هن they will gather شجرة العائلة، يعني they will gather all information in one file in one portrait showing all types of common disease related to the family. فإذا حكينا عن قصة الكرونيك ديزيز رح بلش مثلا نحن إذا بناخذ رح نعطي في example قصة البريست on ovarian cancer and family health history. This is a very big topic. If you will be talking about it, it might take hours, it might be taking days, but uh, briefly to talk about it, family history, family history, family history, family history. In terms of the breast cancer and ovarian cancer and different type of cancer, especially for the female, ربنا يحفظهم جميعا, we need to look after the family history. And again, not 100% because a lot of patients, they had a breast cancer and ovarian cancer and there is no family history. Till this moment, there is no clear evidences showing if there is the family history. يعني what are the main reasons? Then we need to focus and we need to know that the family history is the main what can we do. فإذا مثل ما حكينا هو بهذا الموضوع الفحص المبكر هو كتير مهم. إذا الفحص المبكر هو كتير مهم بهذا الموضوع. how to do when يعني شو هي أول فحص مبكر نعمله بهذا الموضوع. What do you think؟ ثانك يو. فإذا أول شغلة هي السلف اكزامينيشن. أوكي، سلف اكزامينيشن. بتبلش السلف اكزامينيشن وليتر اون، يعني الخطوة الثانية ببلش سبيشالي برجع بحكي دوز فور فاميلي هيستوري. يعني هن الأشخاص اللي فاميلي هيستوري ببلش من عمر، يعني على عمر من 35 وما فوق ببلش قصة ينطلب at least one time per year ينعمل ايكوغرافي. and فوق ال 40 سبيشالي اللي برجع بقول فاميلي اوف ريسك ممكن كل سنة سنتين ينطلب ماموجرافي. اوكي، فاذا بتبلش القصه بالسيلف اكزامينيشن، وبنرجع بعمر معين اذا سواء في ولا ما في. يعني ما بقى، يعني صراحه بدي لكم اياها بهذا الموضوع ما بنحكي عن فاميلي هيستوري حتى. everything everyone is at risk، والاشياء كثير كتراني بشكل مخيف. مشان هيك دائما السيلف اكزامينيشن على طول. وبيعمر معين فوق ال 35 ينعمل ايكوغرافي، وبيرجع كل من ال 40 وما فوق كل سنتين اذا ما اذا الايكوغرافي كل اشتكي بيسوى ينعمل mammography on every 2 years just to make sure that everything is under control. هيدي على موضوع البريست والكانسر family history، فأنا it needs to be under control. colorectal cancer كمان من الأشياء اللي we have a lot of population at risk. We have a lot of population uh, suffering with these types of cancer, colorectal cancer. Now, what should be done? What shall we do? This is a big question mark. Now, again, family history على موضوع الكوليكتر في كتير statistics انه الفاميلي هيستوري هي شغلة جدا يعني يعني شو بنعمل؟ what will be the first detection of the colorectal cancer؟ أول شغلة اللي نحن we need to detect the early signs and symptoms. يعني إذا أنا بعمر معين بلشت أعاني بموضوع الكونستيبيشن أو الدياريا، بالأخص موضوع الكونستيبيشن اللي هو أكثر يعني ضررا بهذا الموضوع، وعندي فاميلي هيستوري، بلش أحط كويشن مارك. كثير مهم أنا أشتغل على موضوعين. على الموضوع الأول ألا وهو أنه بعمر معين، بالأخص for those who has a family history، اللي عنده مثلا البي الوالد أو الوالدة عندها هذا النوع من الكانسر. كثير مهم كمان بعمر معين بلش موضوع الكولونوسكوبي. فإذا بلشت أشوف الأيرلي ديتكشن، أشوف موضوع الكولونوسكوبي وشوف إذا هالمريض فعلا يعني عنده ريسك. لأنه والفاميلي هيستوري playing a very plus working on the lifestyle من خلال ما شدد كثير على المأكولات اللي ممكن هي we call it the heavy meals، يعني الأكل المأكولات اللي دسمة واللي فيها كتير كاربس واللي بتعمل constipation. على العكس ركز على المأكولات اللي ما بتعمل constipation ولا ما تكون كتير spices. يعني مثلا أشياء الفايبرز وأشياء يعني لاحظته كتير عم نحكي عن موضوع الفايبرز. فإذا هون كتير مهمة اللايف ستايل، healthy foods, exercising, and at some age to start doing colonoscopy for the early detection, especially for those who have a family history about these types of disease. وإذا مثل ما شفتوا يعني الإيج مثل ما لاحظتوا هنا آه، بيلعب دور كتير مهم. وضحت؟ الفاميلي هيستوري اوف diabetes كمان، يعني ما راح نكرر المواضيع. بعتقد الدكتور خلال فترة الصباح تكلم عنها بشكل كتير كبير. فإذا هون كمان تكلمنا عن الديابيتس والرول تبع الديابيتس وإلى آخره. أوسيوبوروزس كمان من الأشياء اللي كتير مهم ينحكى فيها، ألا وهي أوستيوبوروزس، لأنه سبيشالي هو ار اتريس. مين حسب رأيكم هن الأكثر أشخاص اللي معرضين لموضوع الأوستيوبوروزس؟ who are the people who are at risk؟ مين هم الأشخاص at risk بهذا الموضوع؟ إذا بموضوع الأوستيوبوروزس دائما especially أكثر أشخاص هن do you think which one is at high risk، الميل ولا الفيميل for example first؟ دائما الفيميل they are at highest risk of osteoporosis compared to the male. excellent. فإذا الفيميل هن أكثر عرضة. if one of your parents had a broken bone, especially a broken hip, you may need to be screening earlier for osteoporosis. لأنه كيف أنا بعرف؟ يعني مثلا الدايابيتس أو الكانسر معروف دغري، ما يخبي حاله. أنا الأوستيوبروزس ما بعرف كيف بدي أعرف أنا إنه يعني صار عندي osteoporosis أو I'm at high risk. very simple. إذا بالهيستوري عندكم شفت عم بربطها بالفاميلي هيستوري. for example in the age of 60 your father he was walking, suddenly he fell down and he had a hip fracture. يعني مش طبيعي واحد دغري يصير عنده فجأة ماشي وقع بالأرض صار في عنده hip fracture. فإذا هيدي بتعطيني فكرة إنه ليش أنا أو والدي أو والدتي بهالعمر كانت ماشي بشكل طبيعي وطاحت على الأرض وصار في هيب فراكتشر. فإذا ممكن يكون في سبب، السبب ألا وهو الأوستيوبوروزس أو ترقق العظام. فإذا I need to do all يعني بلش ال early detection. ايش اسباب الاوستيوبوروز غير الفاميلي هيستوري للاشخاص اللي ما بيتعرضوا كثير لاشعه الشمس واللي ما بياخذوا المواد الغذائيه بما هي الكالسيوم والبوتاسيوم، اللي هي اكثر مواد ممكن يكون فيها مواد على وتعرض للشمس بشكل كثير مهم. يعني نحن آه، بالاخص نحن سكان المنطقه الخليج مش مسموح لنا يعني يكون عندنا اوستيوبوروز صراحه، لانه نحن اكثر اشخاص معرضين للشمس والحراره. بكفي اذا عندك من شهر 4 لشهر 9 درجة الحرارة، شو بكفي جولاي وأغسطس مع درجة حرارة 50 وهيك. يعني مش مسموح ما يكون في عنا نتكلم بموضوع الأوستيوبوروز. الهارت ديزيز. What are how can we promote the heart of our population؟ شو على موضوع الهارت ديزيز؟ الهارت ديزيز do you think it's يعني a family history؟ yes. lifestyle؟ 100% yes. أمراض إيش هي الأشياء اللي تسبب لأمراض القلب والشرايين؟ ألا وهي قلة الحركة، التدخين، أمراض السكر اللي هي بتنشف الشرايين وبتضيقهم، الأكل السيء اللي بيسبب بيعدم انسداد للشرايين من خلال اللي يعني يعني الشحوم والسكر الشرايين. والمريض بيصير في عنده يعني what we call the heart attack or the heart disease. إذن هيدي كلياتها أسباب تلعب بشكل مباشر بموضوع الهارت أتاك أو هارت ديزيز. هاو يعني هاو ات كود بريفنتد مثل ما حكينا اللايف ستايل، الامتناع عن التدخين، الامتناع عن المأكولات المضرة واللي فيها كثير كوليسترول وسعرات حرارية، والمشي والوقاية من أمراض تصلب الشرايين والكوليسترول وإلى آخره. family history and planning or for pregnancy يعني كمان يعني this is another يعني if you have planning to have a pregnancy. فإذا if there is a plan for pregnancy we need to be aware about the family history إذا كان في history بالفاميلي العلاقة بالأمراض وال يعني for example if you have infertility trouble getting pregnant يعني كان في بالفاميلي أو أي إلى آخره two or more miscarriages a previous pregnancy or child with a genetic disease of birth defect or a baby who died at less than 1 year of age. هذه كلها if you are planning for pregnancy يعني كثير مهم لأن موضوع البريجنسي هو موضوع جدا دقيق وموضوع جدا صعب للفيميل طبعا يعني لأنه في كثير من الكومبليكيشن فإذا we need to be aware about some of the history اللي ممكن جد يعني تبين خلال الحمل مثل ما حكينا يعني إذا في مثلا miscarriages في يعني or في genetic disease or birth defect أو إذا عندكم يعني baby who pass away less than 1 year. إذن we need to use our family history to improve our health. إذن family history ناخدها to as يعني واجب اللي قلنا عشان to improve our health لأنه if you don't have a family history إذا خدتها بطريقة إيجابية مثل ما حكينا الأشياء ما أقدر أغيرها بس بقدر استعملها إيجابا عشان أمنع الأمراض والوقاية مثلا healthy living habit blood sugar testing mammogram colorectal cancer screening وإلى آخره فإذا knowing it's not enough مش بس أعرف إنه عندي family history we need to act on your family history by has your mother or sister had breast cancer for example talk with your doctor about whether having a mammogram earlier is right for you. Do your mom, dad, sister, or brother have diabetes? Ask your doctor how early you should do screening for diabetes. Did your mom, dad, brother, or sister had colorectal cancer before age of 50? Talk with your doctor about whether you should start getting colonoscopies earlier or have done donor. Okay, فإذا this is for the first session. في أي سؤال نروح على المحاضرة الثانية؟ إذا في أي سؤال تسألوني عن المحاضرة الأولى قبل ما أروح على الفقرة المحاضرة الثانية. If you have any question, please let me know before moving to the next and last session. Okay, no question. فإذا بس أعطوني دقائق قليلة عشان أغير سكرين وأكون مع المحاضرة الثانية. أي سؤال أعطوني بس دقائق بعد ما خلصنا بدي أغير المحاضرة وأكون مع السيشن. اوكي، جود افترنون، السلام عليكم. تسمعوني كويس؟ اوكي جريت. طيب، رح نكون مع يعني رح نكون في محاضرة على pain assessment. and for example if you have a patient who had a his diabetes type 1 who had a long-term complication of diabetes. for example ايش هي الكومبليكيشن تبع الدم؟ مثلا عنده ميكرو or macro angiopathy، يعني صار في عنده amputation for example of the right leg، صار في عنده يعني gangrene و we tried everything but still now خلص he has a long complication of diabetes وصار في عنده amputation and he's going to suffer from a pain. فإذا there is any relation between the chronic diseases and the pain for sure. Yes. What kind of complication what kind of relations? It's based on that complication. يعني أنا بصير في عندي complication على موضوع معين، patient post heart surgery open heart surgery نتيجة الدايابيتس والهايبرتنشن صار في عنده cardiac problem heart disease كمان he's going to suffer of pain. yes. فإذا it's not there is no way just to have a major surgery without no pain. There is no way to have patient with diabetes food with gangrene and he's going for amputation and there is no pain. فإذا pain there is a very strong relation. We need to know about it and to work on relieve the pain of our population after, in case your patient will arrive on the end stage of the diseases. يعني بنكون على بالأخص يعني ما راح يكون المعاناة المريض بالبين بالوجع والألم بالمراحل الأولى من الديزيز، راح يكون بالمراحل الأخيرة اللي رح نتكلم عنها، اللي نتكلم عن البين بشكل. فإذا pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. فإذا pain هو ممكن يكون actual or potential tissue damage. رح نشوف يعني what do you mean. Pain is the experiencing experience says it's existing whenever he or she says it does. فإذا رح نشوف نحن فإذا إنه البين we have two types of pain. إذا نحن بموضوع البين عندنا نوعان من البين ألا وهو الأكيوت وهو الكرونيك بين. Do you think which one is worse؟ أي هو يعني it's worse for the human being الأكيوت or pain or chronic pain and why؟ إذا حسب رأيكم أي؟ إذا طبعا هو الأكيوت بين لأنه this is something that on spot. يعني مريض ما راح يكون he has a chronic chest pain، ما في منها هيدي. there is no way there is no way to have a lower chronic lower abdominal pain عم يعمل مثلا مريض انوريزم، ما في وقت. اذا دائما الاكيوت هي الخطره. هي الكرونيك بين عدة اسباب. يعني ممكن تكون مع المريض، ممكن المريض يكون عنده يعني some of the disease which is just chronic pain only. من الأكيوت it's more worse because we need to know identify the cause. بالchronic pain already we know the cause. أنا بالacute pain I need to know what are the main cause in order to do the proper treatment. ما to treat the cause. يعني أنا ما في أنا خفف الألم عن المريض بلا ما أعرف إيش السبب. بس first of all بالacute pain difference it's بالacute pain I need to know the cause on spot to give the proper treatment on spot. بينما بالchronic pain last for a indefinite period. يعني بيكون معروف انه المريض صار له 6 شهور عامل عمليه مثلا عمليه كبيره وعنده الم، بعد ما ارتاح صار له 3 4 شهور 5 شهور 6 شهور سنه يعاني من الالم وما معروف شو السبب او there is no treatment or ممكن يكون هي يعني predict that he has pain and there is no pain. ما فيني اعرف يعني. اوكي يعني بس ما في مريض يكون على acute pain على يعني اشهر. مثلا acute pain resolve within a given time frame. انا اذا مريض عندي chest pain ما في يعني it's timing is very important and I need to solve the pain as soon as possible. ليش؟ لأنه إذا ما دام chest pain not treated يصير عنده myocardial infarction. يعني احنا بنسمع اللي بيشتغلوا بالطوارئ بيعرفوا انه في كثير من المرضى بيقولوا لك والله اجى المريض صار في عنده الم بالصدر وتوفي على باب الطوارئ. ليش؟ لانه هالمريض كان عنده chest pain not treated صار في عنده myocardial infarction، هو على باب الطوارئ صار في عنده بنسميها ان Arabic الجرحى القلبيه. يعني هنحفظ موضوع الاي سي جي pulses في تك اور في اف. اذا صار في عنده ذبحه صدريه وتوفي اون سبوت. اذا identified and treated within a given time frame. هاد تايم فريم. ونفس الموضوع موضوع ستروك كمان. بينما الكرونيك بين يعني ما راح مثل ما حكينا ما راح يكون مريض عنده chest pain for 3 to 6 months، بس كرونيك بين اذا الموضوع تخطى 3 اسابيع بنبلش نحطها as a chronic pain. وهون فاذا بنحكي على chronic pain it's usually for 3 to 6 months. الأكيوت pain it's responding well to opioids and non-opioids therapies، بينما it's difficult to take completely. يعني في مرضى بكون عندك أنا عندي مايالجيا، عندي آلام بالعضلات for example على long period of time، ما بعرف شو السبب ولا لها علاج، باخذ كل الميجرز بس هيدي الكرونيك. بينما هون acute pain ممكن أعطيها pain killer، ممكن opioids، ممكن أعطيها steroids، ممكن أعطيها different pain killer and it will be solved on spot. اوكي ممكن مثلا بعطي البانادول، ايبوبروفين، بعطي الاركوكسيا، ديفرنت ميديكيشن حسب البين كيلر يعني ال ال عشان يخفف قلب. إذن this is the difference between the acute pain and the chronic. طب let me give you an example. Pain experienced by endotracheal suction in an ICU patient is classified as the following. فإذا صار في عنده وجع أثناء الاندوتراكيال سكشن. المريض اللي عنده اندوتراكيال تيوب، مكنة التيوب تبع مكنة التنفس الاصطناعي. What type of pain we could call it as chronic pain, as continuous pain, as acute pain, or as visceral pain? Which one would you put? إذا عنده اندوتراكيال عم بعمله سكشن صار في عنده he experience a pain. How it will be classified, or under which category this pain is classified as what? This is classified as acute pain. Right. Now, if I have a patient who is, for example, if I have a patient who is mentally or is, he had a amputation, صار في عنده amputation, and this patient he is in the ICU. لازم طبعا انا ما معقول يكون عندي مريض بوست هارت ترانسبلانت or major heart surgery or heart او عمل له amputation بوست بدون ما بدون ما اعرف انا يعني بلا ما يكون بالاي سي يو. ايش هي الاشياء اللي بتخلي هالشيء يصير؟ يعني ايش هي انواع البين اللي ممكن تصير affecting pain in the critical physical, emotional or environment. بنبلش. Some of the procedure it might lead to pain. يعني some of the procedure ممكن هي بحد ذاتها تسبب pain. مثلا if you are going to change the position of a person from time to time. مريض he has a hip fracture or he has amputation and he is in a position على position معين and I'm going to change the position from time to time. from, for example, every 2 hours in order to avoid the pressure injury. It's going to create a pain. مظبوط ولا لا؟ يعني it's the movement of the patient, especially bedridden patient, it's it's going to create a tracheal suction كلما ممكن، لأنه ممكن أنا يعني exciting the nerve، أو ممكن أجرح المريض وإلى آخره كمان. it might create some types of pain. deep line removal. أنا مريض عنده for example عنده a central line. I have different types of line. While moving it might create a pain. deep breathing and coughing exercising. المريض اللي بيكون مثلا he's on the way just to ambulate him or to move from a bed to another bed, or for a patient to another patient. sorry, from bed to bed of unit to unit. بدي يعملوا physio exercising or respiratory exercising. ممكن هذا المريض يعني هيك. dressing change. while doing the dressing، أنا مريض عنده مثلا amputation. I'm going to do the dressing for the patient. بتعرفوا it's very يعني الله يعين المرضى. بيكون very ممكن يكون infected، ممكن يكون there is pus, there is bad smell, there is infection. It's very hard to touch it. It's there is discharge. فإذا this is it will create a severe pain for the patient. drain removal. مريض عنده chest tube، مريض عنده for example while moving بنقول للمريض take a breath، لأنه ممكن he might have a pain. and explain, and always we need to explain the procedure to the patient. طيب, what are the benefit of pain relief؟ ليش بنعطي pain relief للمرضى؟ فإذا there is a lot of effect, there is a lot of benefit of having uh, of giving a painkiller. أول شغلة فإذا البين or benefit of affecting pain relief, it's going to work on the system سواء cardiovascular or respiratory or neurological or GI or musculoskeletal أو وإلى آخره. economic رح نشوف كمان playing a role. cardiovascular what؟ البنفيت it will المريض يكون عنده tachycardia والhypertension, and as it will decrease the pulse rate and it will decrease the blood pressure. مريض يكون hypertension it will إذا بتخفف من الضغط أو ال blood pressure. it will decrease the pulse rate and it will decrease the blood pressure. فالموضوع respiratory it will enhance the respiration, oxygenation, ability to perform deep breathing and coughing exercise, and decrease incident of pulmonary. فإذا نحن وقت مريض عنده مريض if he has a severe pain cannot move. مضبوط؟ يعني إذا المريض أنا عنده آلام موجعة for a reason سواء acute or chronic، يعني أي شخص منا بيكون عنده pain، أول measurement بياخدها هو to be sleeping on the bed. بيقول لك بنام على وجعي. هذا هالشيء بيأثر على الدورة الدموية، على الريسبيريشن، على الكارديوفاسكولار. طيب بينما نحن هنا if we give a painkiller فإذا it's going to enhance the respiration، تنشيط جهاز التنفس عند المريض، في تنشيط الاكسجينيشن او يعني الساتوريشن، الابيليتي تو بيرفورم ديب بريدنج اند كافينج، المريض بيصير فيه يشعر ويتنفس بشكل احسن and would decrease the incidence of pulmonary complication. neurological. ايش اهميه البين كيلر؟ اكثر شيء على النيورولوجيكال، لانه it will decrease anxiety and mental confusion and it will enhance the sleeping. فاذا بالنيورولوجيكال it will decrease الانكزايتي. يعني أنا وقت عندي ألم I will be under pressure, I will be mentally confused, mentally sick, mentally depressed. عشان هيك كثير أنا بموضوع النيورولوجيكال كثير مهم إنه المريض يعني to give a painkiller in order to affect the anxiety or to decrease the anxiety and mental confusion. على موضوع الجي اي what will be the impact. أول شغلة it will enhance the gastric emptying, promotion of positive nitrogen balance and increased appetite. إذا هيدي يعني بموضوع الجاستريك it is the one. الماسلوسكيلتال earlier ambulation المريض كل شيء ما في ألم، كل شيء هو متألم رح يضل نايم ما يتحرك. If there is no pain he's going to early ambulation. Early ambulation, especially those who are suffering of complication of chronic disease and they are bedridden, cannot move, very important. ليش؟ بالخاص المرضى اللي بيكونوا عندهم chronic disease مثلا مريض وعمل له سوى عملية كبيرة early ambulation ليش جدا مهمة على موضوع musculoskeletal. What is the reason? And because early immobilization and it will reduce the complication of immobility. أعطوني واحدة من complication of immobility. Then give me one complication of immobility of patient like what؟ ما حركنا المريض. أعطوني one complication إيش يصير؟ يلا very easy. Then what are one of the complication of the early ambulation or the complication of immobility? Pulmonary embolism, yes or no? ايش غير؟ فاذا pulmonary embolism هي من اكثر اذا المريض عنده bedridden cannot move ممكن يصير في عنده pulmonary embolism. economic شو هو الeffective of pain relief على موضوع economic of the patient؟ decrease length of stay يعني المريض بدل ما يجلس فترة 5 أيام ممكن يجلس يومين لأنه كل ما زادت اللينث اوف ستاي كل ما التكلفة تزيد أكثر وأكثر. فإذا الكوست نحن بتعرفوا مثلا مريض in one night of ICU it will cost a huge amount of money. مريض he has a pain he's not going to leave the unit for example. فإذا هيدي كلياتها benefit of effective you know tolerance physical dependence and addiction. فإذا رح نشوف شو هي how to do the فإذا it's very important to do a proper pain assessment. But if there is no proper pain assessment, we cannot control the pain. Do you have any idea how to do a proper assessment for the pain؟ نحن كيف نعمل assessment؟ أول شيء على أي أساس نعمل assessment؟ Based on what؟ فإذا based on what I will do assessment. فإذا أول شيء حسب type of patient أنا ما في أعمل assessment للبيدياتريك مثل ما بعملها للأدلت وما في أعمل assessment للمريض الكونشس patient مثل unconscious patient ما في أعمل assessment للمريض حسب الفنتيليشن اللي هو كمان بيحس بالألم مثل المريض اللي هو is fully conscious. فإذا دائما نوعية المريض أو what are the complaint of the patient هي بتخليني أعمل pain assessment. فإذا there is no way to treat the pain unless we did a proper pain assessment اللي هي would you or do you have idea about types for example عندي الفلاك والفراك اللي هي بتختلف بين الأدلت والبيدياتريك وعندي مريض بيكون على الفنتيليتر. Do you think المريض who is ventilated he might have a pain? What do you think? إذا المريض على الفنتيليتر هل يا ترى he has a pain? For sure yes. How I will know؟ كيف تعرفي؟ إذا المريض he is unconscious كيف تعرف إذا عنده pain؟ من خلال الفنتيليتر settings بنعرف. أوكي فإذا we need to assess the pain and reassess the pain. Okay, very important to assess and reassess the pain. And to use a standard pain scale. Now My question, which of the following is the most reliable standard of pain assessment؟ يعني هي أكثر شغلة reliable يعني موثوق فيها بموضوع البين assessment هي الobservation, patient self-report, blood pressure measurement, or level of sedation. What do you think? Which one? Most reliable standard of pain assessment. What do you think? Which one is the most reliable standard of pain assessment? Patient self-report أكيد لا، لأنه المريض ممكن يعطيك a false report. Blood pressure measurement طبعا لا، لأنه ممكن يكون blood pressure high but مش because of pain. level of sedation طبعا لأنه المريض كان over sedated I won't notice anything. فإذا this is by what? By observation. ممكن أنا أعطي false observation. فإذا في عندي 4 trick question. هتيجي at patient self report لأنه المريض يعني if he's going to pain and he reported you need to notice this, you need to observe. معقول المريض يكون عم يبكي من الألم وهو يقول أنا ما عنده ألم. فإذا whatever he report it needs to take into consideration. Now what are the pain uh, what are the painkiller؟ فإذا إيش هو البين intervention؟ من خلال we have the non-opioid analgesia, opioid analgesia, spinal analgesia, epidural analgesia, intracheal analgesia, sedative analgesia, and hypnotic agent. مثلا الopioid like what? Give me example. Give me example of opioid. يلا. Do you have any idea? Give me example of opioid medication like what? يلا المفروض مشاركة أكثر. هنعرف اليوم الخميس بآخر دوام but يلا it's around the 20 minutes وخلصنا but give me example like what? Do you have any example? المورفين مثلا how would you classify it? For example, it's mainly used to relieve pain, especially those who have after surgery or during, for example, cancer treatment. Okay, and then this is one example. Dosing, administered oral, rectal, or IM, IV, and side effects: constipation, urinary retention, sedation, respiratory depression. فإذا هودي كثير المرضى ممكن أو ممكن هودي الكيسات ممكن يعملوا what we call a respiratory depression لأنه إذا بينعطوا على دوزج عالية ممكن يعملوا. فإذا هيدي الأدوية it needs to be under control لأنه ما نسمح فيها نعطي high dosage وكل ما المريض إذا he has a هون بس بنعطي إذا he has a severe pain إذا كان عنده ألم شديد نتيجة major surgery نتيجة treatment of cancer ساعتها بنروح نعطي على الأوبيويد. benzodiazepine control anxiety and muscle spasm, produce amnesia. Midazolam is recommended for conscious sedation. مريض اللي بيكونوا امتى بنعمل conscious sedation؟ فاذا اعطوني بعد الحياه نعمل فيها الكونشس sedation بنعطي ميدازولام لايك وات؟ اذا امتى بنعطي conscious sedation؟ give me example. بعدنا عم نحكيها بالسيشن الاولى. مثلا وقت نعمل الكولونوسكوبي فور اكزامبل ممكن نعملها اندر كولونوسكوبي. إذا ممكن نعملها ميدازولام is recommended for conscious sedation reversible with clemizine. أوكي. مثلا هيدي كمان this is one of the indication for propofol like what? It's a rapid acting sedation need appropriate airway and ventilation management. مثلا when you will give the propofol which case? فإذا وقت عم نعمل جنرال سيرجري، فإذا هيدي كلياتها كمان ايش هي الممكن non pharmacological. حكينا عن بعض الفارماكولوجيكال intervention. Give me example of a non pharmacological intervention، يعني الاشياء that غير الادويه اللي ممكن تشتغل موضوع البين كيلر. مثلا environmental modification like what؟ how the environmental modification is playing، يعني ال environment is might support the pain of the patient like what؟ give me example. كيف يعني give me example كيف ال environmental or environment it might support the it's under a pain relief for the patient like what؟ مثلا changing the room of the patient، a room with a good view. مثلا هيدي كلها بتأثر عند المريض. مثلا we have a smart technology in the room to provide the patient with iPad, to provide with smart bed, with he could يعني nice food, a nice walking area, nice يعني هيدي كلها it's environment modification that it might support the pain for the patient. Distraction, relaxation technique, مساج والى اخره، هيدي كلها we call it a pain intervention. فاذا نحن في كثير من الانترفنشن that we might do it ممكن نحن تساعد على الموضوع المريض البين عند المريض. فاذا just to resume it انه نحن بموضوع البين في كثير من المرضى على كرونيك ديزيز سبيشالي بنبلش نضطر على موضوع البين وقت ببلشوا بفوتوا بالكومبليكيشن الكبيره، يعني الكومبليكيشن اللي هي اند ستيج. المريض ببلش مثلا اذا اخذنا مريض السكر اللي بيسبب ممكن يسبب مع الوقت ميكرو اند ماكرو انجيوباثي، يعني بيصير في ضعف بشرايين العين، بيصير في ضعف بالشرايين الرجل، بطل يحس المريض باجره، بصير في عنده جانجرين ينعمل له امبيتيشن، وبعدين بفوت على الاتش بي او. يعني في كثير من الاشياء هي تسبب سيفير بين. مريض بيصير في عنده هارت اتاك بيضطر يفوت على الاو ار، بنعمل له اوبن هارت سيرجري and he's going to stay for CSIC for a days، ويضطر ياخذ سيفير بين كيلر. لانه يو كود ايماجين انه مريض بس مشان تفتح صدر المريض how much it's painful كمان هيدي it's فاذا شفتوا قديش الريليشن قويه بين هذا الموضوع. what will be the solution؟ نرجع السوليوشن هي الاساس، الا وهي يعني السوليوشن الاساسيه الا وهي يعني ايش هي الاسباب اللي خلت هذا الموضوع يصير. now already if I have a patient who post يعني complication of a disease and he has it's normal to have a pain، بس أنا بدي انتبه على موضوع البين assessment كتير لفرد سبب، لأنه المريض I am sure he has a pain. أنا إذا ما في أعطي هيك medication by default، يعني كل ما هيك، لأنه المريض عنده chronic disease وعنده major surgery وعنده amputation وعنده open heart surgery بعطي الميديكيشن at any time. لا I need to be careful، لأنه كل ما أعطيت ميديكيشن بشكل أسرع الميديكيشن في complication. فإذا الميديكيشن في من وراها complication، مثلا وحدة منه هي الريسبيراتوري ديبريشن. اوكي، وبعدين مش بس هيدي الكلينيكال، كمان في شغله كثير مهمه انه المريض اصلا هو بحد ذاته ممكن يصير ادكتد على موضوع الميديكيشن. يعني انا مثلا I noticed one patient يعني he was post يعني spine surgery، وثابت انه هذا الشخص هو in a good relation with one of the staff. صار هذيك staff يعني عن حسن نية يعطيه بهالميديكيشن ظنا منه انه he is doing a great job، بس مع الوقت بعد اسبوع او اسبوع ونص صار المريض addicted على هذا الموضوع، وصار هو يعني وقت يكون ما يكون هذا الشخص على الدوام صار يطلب الميديكيشن بشكل كتير منيح. ومرة من المرات انه حتى صار يكسر وصار يعمل مشاكل كبيرة باليونت. ليش؟ لانه الميديكيشن was not given، وهو بطل بحاجة للميديكيشن. يعني صار on day 10 post OR وبطل في هيك severe pain، بس هو صار كتير يعني يتطلب بموضوع الميديكيشن ويعمل وبده إياه. فإذا I need to do a proper pain assessment. ال pain assessment مثل ما حكينا بتختلف بالpopulation وبتختلف بالtypes of patient. لأنه أنا البيدياتريك ما في أعمل نفس البين أسسمنت تبع الأدلت. حتى الأدلت كونشس غير الأدلت أنكونشس، والأدلت على الفنتيليتر بتختلف، لأنه ممكن أنا أعطي أوفر سيديشن والمريض يعني يلبي أوفر سيديتد ويصير. فإذا هيدي من ناحية الميديكيشن already أعطيتكم example عنها. I give you an example about the medication, the painkiller والأوبيويد والبنزودازيبين والى آخره. وفي كثير من what we call it the pain intervention which is non-pharmacological، يعني هي إجراءات الناخدة للبين ما تحتاج الأدوية، مثل زي إيش environmental modification like distraction، يعني المساج environmental وإلى آخره. هيدي كلياتها ممكن الأشياء. فإذا this is the pain session. والمحاضرة الأولى تكلمنا إنه how much the family history is playing a vital role in the prevention of the chronic disease. تكلمنا عن قديش الفاميلي هيستوري موضوع ال chronic disease، واعطينا example على اعطينا example. فإذا شو هي relation بين الفاميلي هيستوري والchronic disease، واعطينا example إنه مثلا مريض مثل موضوع الدايابيتس، موضوع الهايبرتنشن، موضوع الكانسر، موضوع مثلا سواء الاوفيريان كانسر او البريست كانسر او الكولوريكتال كانسر. حتى حكينا عن موضوع الاوسيوبوروزس، قديش موضوع يعني how we notice that we are at risk or we have osteoporosis. وحكينا كمان قديش الكوميونتي is playing an important role في موضوع الوقاية من الكرونيك ديزيز من خلال السكول، ومن خلال الاشياء اللي بنعملها بالسكول، ومن خلال الكوميونتي، ومن خلال يعني من خلال الأندية الرياضية. وقديش في اورجانيزيشن لحد الحين هن كمان بحد ذاتهم عم بي يعني they are providing يعني 1 hour for example يعني activities للإمبلويي وإلى آخره. فإذا هيدي is to resume our session. Do you have any question؟ إذا في أي سؤال عن المحاضرة الأولى والمحاضرة الثانية. If you have any question, please let us know before ending everything قبل ما نخلص. If you have question, I'm ready to. طيب. If there is a question فإذا thank you for attendance، وكل الشكر للمنظمين على دعوتنا للويبينار to be a speaker. و thank you for your attendance and see you with another webinar. يعطيكم ألف عافية.